Hello and welcome to the 19th Represents, Resilience and Recovery. I'm Amanda Zamora, co-founder and publisher of the 19th, an independent nonprofit newsroom that aims to empower you with the information, resources, and community you need to be equal participants in our democracy. Today, we are pleased to bring you critical conversations on the nation's fight to defeat COVID-19. We will hear from the women leading the Biden-Harris administration's coronavirus response, state leaders blazing the trail in vaccine distribution, and the frontline researchers and healthcare workers battling misinformation and racial disparities as they race to vaccinate millions of Americans. As we mark 1 year of living through the pandemic, we hope these conversations will shed light on the road to recovery and the lessons we hope to take forward. Before we get started, we'd like to thank founding sponsors 3M and AmerisourceBergen, and our presenting sponsors, Pfizer and the Healthcare Distribution Alliance. Gina Clark, Executive Vice President and Chief Communications and Administrations Officer with AmerisourceBergen, will share a few remarks before we get started.
Thank you to the 19th for inviting us to participate in today's event and support the critical issue in conversation around gender equality, particularly across the healthcare industry. I've had the pleasure of working in healthcare for nearly 30 years and have witnessed the ingenuity, innovation, and positive impact my colleagues, peers, and organizations have had on the patient experience and health outcomes. I've also experienced firsthand the growth that's taken place to recognize and celebrate women's voices at all levels across healthcare. That said, while I'm proud of the work that's been accomplished to date, we must stay keenly focused on our obligation as women, as leaders and as citizens to do all that we can to champion for equality and create a permanent impact for generations to come. At AmerisourceBergen, a global health company, investing in our people and culture is critical to delivering our purpose of creating healthier futures for all. Our associates are on the front lines ensuring every day that medication is delivered safely and securely and on time to the patients and providers who depend on it. Our work begins with people, focuses on being a part of the solution, and celebrates individuality without prejudice or glass ceilings in order to make a difference in our communities. By providing a safe and encouraging environment to think bigger and challenge the status quo, women have taken on instrumental leadership roles and positively shaped the company, culture, and our impact across the world. Being intentional in how we cultivate and amplify female leadership, thought, and perspective is paramount for developing gender-inclusive healthcare solutions that will inevitably improve outcomes for vulnerable populations. I am proud of the progress we've already made, and I'm excited about the momentum ahead to shape inclusivity across our industry.
A quick reminder that while sponsors help keep the 19th Represents free for viewers to attend, they play no part in the programming of our events. As today's discussion gets going, we hope you'll help us spread the word by tweeting and sharing with the hashtag 19thRepresents. Now, on to our first keynote conversation. Dr. Rochelle Walensky is the director of the Centers for Disease Control and Prevention and an influential scholar whose pioneering research has helped advance the national and global response to HIV/AIDS. Dr. Walensky is one of America's most respected experts on the value of testing and treatment of deadly viruses. Dr. Marcella Nunez-Smith chairs President Biden's COVID-19 Health Equity Task Force. She's the principal investigator on many NIH and foundation-funded research projects, including one to develop a tool to assess patient-reported experiences of discrimination in healthcare. Her research focuses on promoting health and healthcare equity for marginalized populations. Leading this conversation is the 19th healthcare reporter, Shefali Luthra. Shefali?
Thanks, Amanda. I am so excited to be here with Dr. Walensky and Dr. Nunez-Smith for this panel, which I think will be really informative. I wanted to start with what's in some ways maybe the most obvious question, which is just quite simply, looking ahead, what are the biggest challenges we still face when it comes to reaching women, and especially Black women and Latinas who have borne so much of the brunt of this pandemic? and making sure that they're actually able to access vaccines?
Maybe I'll just start and say thanks for having us. I'm really excited to be here. I think we should just pause for a quick minute and say we are a year into this pandemic. And if you had asked anybody a year ago, they would have never said that we would have 3 highly efficacious vaccines in a year's time. And I would say, while we have been moving quickly, the science has not suffered. We've enrolled over 100,000 people collectively in these clinical trials. We've had a lot of disease, so they've enrolled quickly and we've gotten outcomes quickly. But the fact that we have 3 vaccines that we know are safe, that we know are efficacious, ready to put into the population is truly a historic scientific feat. So one might have thought that that wasn't possible, and here we are, it's possible. So now we actually have to do the next really thought to be impossible, but we're going to make it possible thing, and that is to get it into 300 million Americans. And so that is the hard work of what we're engaging in and what we're doing. And you're exactly right to ask the question of how we're going to get it to people who people who want it, and how do we get it to people who may be hesitant to have it now, but who, with more information about the science, about the safety, about their individual risks, how do we ensure that they feel the confidence in this vaccine to then take it? Maybe with that, I'll pass it to Dr. Nunez-Smith, and then we can keep going.
Yeah, great. Thank you so much, Dr. Walensky, and just echoing my appreciation to be here in conversation today with you, as well as Shefali and everyone else. You know, this is absolutely top of mind, right, for all of us, is making sure that the vaccination campaign reaches everyone. You know, Dr. Walensky rightly said, this is a remarkable moment to have 3, right, not 1, not 2, but 3 vaccines that are safe. And I know a lot of questions that I hear about are about safety, but are safe and also highly efficacious. You know, that's just part of it. So absolutely, we need to make sure that people have their questions heard, answered by people who they trust. I think that is just top priority, making sure that all the trusted messengers out there have the good information. We are working so hard against misinformation and disinformation that's out there. You know, if I had $1 for everybody that sends me something that actually there is no scientific evidence for, my kids would all have their college funds taken care of, right? I mean, we have to get ahead of some of the information that just travels so quickly, but isn't true. And I think, you know, there is the differentiation between kind of people who are seeing things perhaps in social media, and I think rightly asking, and then what I think is sad in this moment, which are others who are trying to take advantage of people really having the right to have these questions, but kind of coming in and saying, you know, all vaccines are bad in this moment, and trying to push different agendas that are really political. So, you know, I think it's important we just, you know, take that step back and say we honor, we respect everybody's questions. We will meet you where you are. You know, as an administration, no one is here peddling or selling, right? Vaccines. We want to bring information. We know people are smart and will make good choices, right choices for themselves and their families with more information. And so that is a lot of what, you know, we're going to lean into and lift up in this work to reach kind of everyone in the vaccination campaign.
And I mean, maybe thinking off, right, the relatively recent news around the Johnson & Johnson vaccine, which, I mean, the science is pretty clear that this is a powerful vaccine, right, for preventing against severe illness, for preventing against death. But there clearly are concerns a lot of folks have about how it compares to the other products on the market. And I guess I'm wondering, do you have plans or specific messaging or education involved to help reach folks who are nervous about the vaccine? And is that a concern that you're navigating right now?
I think one thing we have to remember in these studies is they were not compared head to head. I don't think we can actually say that how Johnson & Johnson performed compared to how Pfizer or Moderna performed, because they were compared at different times of the pandemic with different levels of variance in the population. So I don't think these are direct comparisons. I think that what we should say, and what FDA has said, and especially what the Advisory Committee on Immunization Practices at CDC says, is there is actually currently no known preference preference for any given vaccine for any given population. So with that sort of being the guidance from both the FDA and as well as from the CDC, the real question is which is the vaccine that either is available to you, because the real goal is to get as many people vaccinated as possible as quickly as possible. And then there are certain conveniences that make one preferable potentially over another, both in terms of how they get distributed and their ease of distribution, and then in terms of patient preferences as to how many times they can or are able to return.
Yeah, absolutely. I echo all, and I think that there are some key pieces of information that are always worth revisiting and sharing with folks who are asking about vaccines, right? And the process in particular. So one of the things, and I think for, we mentioned and talked about communities of color, one of the things I think is really important for people to know is just the representation at each level of this work. When we think about the scientists who have been toiling, and thank you to them and all those researchers for their work, when we think back historically to some of the darker moments like Tuskegee or Henrietta Lacks, one of the things that was problematic was the lack of representation in terms of the scientific workforce. And it's completely different now. And the development for all the vaccines really features that kind of diverse representation, not just in those scientists, but also in the participants in the clinical trials. People need to be able to see themselves in trials, and we can do that for all three of these vaccines. 30%, a little bit over that for Pfizer and Moderna in terms of people identifying as being of color. And that number much higher even for Johnson & Johnson, up around 50%. And so, that's very, very important. And then in the processes, Dr. Walensky talked about, those processes are free of political interference. Those are independent scientists working with the data. They are transparent. And again, there is diverse representation on those groups and bodies as well. So I think it's just really a great opportunity we have today to pull the curtain back and let people know exactly kind of how these processes go. I have a lot of faith and confidence in the process that got us to this point.
So do you have plans perhaps to do outreach that's maybe targeted toward different groups that may have different reasons for being concerned about when to take a vaccine, what kind to take, whether there's a difference?
Maybe I'll start in the big picture and say that we've done a lot of communicating with our state, local, tribal, and territorial partners. We know at the federal agencies that it is those places that know their localities and they know their people, right? So we can sort of help distribute the vaccine, but they're really going to be the ones that we're going to follow their guidance with regard to how they best reach their people. So that's sort of for the state supply. We last week had a CDC vaccine forum. We had participations from all 50 states, from 120 tribes, from all sorts of faith-based organizations, community-based organizations, to give us their best practices. What are the things, the creative things that they're doing that have made that work? At the federal level, there's a partnership with FEMA and the CDC to look at social vulnerability index and census to see if we can put mass vaccination centers in places that are the most vulnerable, so we can bring vaccination to them. In addition to that, we're trying to bring vaccination to them through mobile units. How do we take those federal vaccination centers, those community vaccination centers that can vaccinate up to 6,000 people a day, but then do further outreach from there on mobile units to really spread that outreach as much as we can. And then we have federal pharmacy partners that are allowing us to partner with pharmacies we know that 90% of people live within 5 miles of a pharmacy. Can we get vaccine to pharmacies where people generally trust their pharmacy? And then finally, we're distributing it to federally qualified healthcare centers. We're planning that over 250 federally qualified health centers will actually have access to vaccine in the week ahead. So we're really interested in those partnerships and trying to make sure we get the outreach to as many places as possible. And then maybe Dr. Nunez-Smith can talk about the sort of on the ground community-based partners as well.
Yeah, invaluable, right? I mean, the success really hinges on the deep partnerships with community-based organizations, faith organizations, those trusted leaders. I just want to underscore the importance of access as a communication and outreach strategy, right? We have to make sure that people, when it's their turn and when they're at yes, that vaccination is easy, right? So we've thought about important structural barriers, making sure vaccines are free, for example. And then of course, some of those innovative strategies that were shared at the CDC forum, things like making sure community-based organizations can help with pre-registration, making sure we're holding slots and spots for particular communities that have been hardest hit, expanding the hours when people can access vaccine and vaccination. So access is part of our communication strategy, right? We're not here just to talk, we're acting, we're doing, we're gonna show up and make vaccines available in community and easy to access. And then, on a national scale as well, very much in the final stages is a national public education campaign. And it is important that we do think about the tailoring of the message. To your point, right? People will have different concerns and we see different groups. Even we've been talking some of communities of color, we see some skepticism in our rural neighbors as well. Like we have to be able to reach out and communicate, addressing head on what people's concerns are. And so that public education campaign that's about to be launched will do just that. Think about tailoring of the message and of course the trusted messenger as well.
Maybe one final note to just say that not everybody wants the vaccine today, but as they see their neighbors getting the vaccine, they may be ready to take the vaccine next week. And so we need to make sure that there are options for people to come back, right? If you passed up your opportunity today, that doesn't mean a forever pass up. That means that we're still available to you if you want to come back.
100%.
Thinking about measuring sort of success, right? One thing I have thought about a lot is sort of the data that we have and data that we don't have when we think about diversity and equity in incidence of COVID, in incidence of comorbidities, and in vaccines. And I mean, it seems really clear that we do have these big holes in race and ethnicity data, and we have shortcomings as well, right, in our historic collection of data for LGBTQ plus people. And I would love to hear a bit about what plans you have to address those longer held demographic issues in data collection and why that's important, especially now.
Yeah, I can start because I'm obsessed with this point. And we definitely need data to drive equity. I mean, that's at the core of what you're asking. Is it's hard for us to know and set our targets, right, when we have data gaps. So it is important and it is a priority to improve data collection along all the lines you're talking about, including race, ethnicity. The president kind of day one, day two executive orders spoke directly to data and made a whole of government call for us to improve our data collection for response and looking forward to recovery. So this is very fundamental and foundational to the work that we're doing in the administration. I would also say that kind of while we are doing lots and working very closely collaborative to improve the both collection and reporting of race and ethnicity, and Dr. Walensky can talk more about that because CDC is at the forefront of that. It doesn't slow us down from actually saying, well, how do we get to equity with the data that we do have? And so having metrics like the CDC Social Vulnerability Index that we can lean into and use at this time to help target resources, incredibly important. But I would say your point is well taken. There are many groups who are invisible in our data, right? And that can be folks who are LGBTQ plus. How long did it take us to even have a better idea what was happening in indigenous communities in this country? Do we still know what's happening in all our prisons and jails and detention centers fully? So every time we kind of let the data hold us back, we are in fact making a choice for what gets priority and what gets acted on. But data and better data and being data driven is at the core of the work that we're doing.
And maybe what I'll add is to highlight the reason that this is important. We've had 2 MMWRs just in the last month, one that demonstrated increased risks of mental health challenges associated with COVID, higher rates in Hispanic populations. We've had another MMWR that looked at rates of comorbidity that would increase your risk of COVID-19, higher rates in the LGBTQ population. So all of these things demonstrate to us we need to have these data so that we can follow these and intervene. So I'm really, what I would say is I'm committed to the work that we are doing at CDC, to the work that Dr. Nunez-Smith is facilitating with our work to make sure that these data are available. And then finally, these data have been not available for years. So finally, let's stand on the shoulders of all the work that we're doing now so that we can do this for every health outcome we're looking at in the future.
Shifting gears slightly, one thing that we have talked a bit about, right, is sort of the challenges around prioritizing equity. And one thing I've been hearing about a lot from public health experts is potential concern around some of the states that are abandoning, right, the priority group guidelines in favor of a strict age band system for vaccines. And the concern there, right, is the implications for racial equity. And what I want to ask you is, I mean, have you been in touch with states that are making this shift? And if we do, in fact, see this having a negative impact in terms of addressing racial inequity, is there a role or a place for the federal government to step in?
Yeah, so I can start us on that, and certainly, federal guidance and federal prioritization, I think that what we suffered from as a country for far too long in this pandemic was lack of federal coordination and lack of federal guidance. And so I think that, for certain, the Biden-Harris administration is fully committed to bringing all the resources of the federal government to bear. And that includes the scientific expertise that has shaped the priority guidelines that are issued through the CDC and ACIP, which Dr. Walensky will talk more about. We have to be centered on equity in this work. This is one of those occasions where it's both the right thing to do, but also the only way, right? For us to be able to get to a new normal on the other side of the pandemic, everyone has to be brought along in this work, right? When we talk about vaccination campaigns only work when we reach everybody who really is medically eligible to take the vaccine. And so we have to stay top of mind. Equity does not happen by default. It never has, and it won't happen that way now. But directly to your question, we do work very closely with states and local health officials. Dr. Walensky mentioned that. We talk on the team many times a week with governors and leaders and on all those health officials on the ground who are thinking about implementing their strategies. And we are here very eager always to provide technical assistance to help people achieve the goals that are set, which is to achieve equity in terms of the vaccine.
Perhaps I'll just add a couple of points. One is when the administration turned over at the end of January, it was very clear that there were some states that had too much vaccine on the shelf because they were so stringent in their requirements and as to who would get it, and that by having those such tight requirements that they were unable to distribute vaccine fast enough. There were other states that, as you said, opened up a very wide spigot and there were too many people in line. And so what we spent a lot of time early on doing is making sure we could have the need meet the supply. And we're still working on that, right? Because we know that the supply has been less. I do think that somewhere in the weeks to month ahead, we're going to be at an inflection point where we're going to have more vaccine and we're going to have people who want it. And what we really need to do now is to ensure that the hard work that we're doing in all of this outreach and all of this sort of groundwork that we're trying to do to reach community organizations and messaging and to counter mis and disinformation is going to really reap benefits when we have so much vaccine. And as Dr. Nunez-Smith said, you have to redouble your efforts in all of this, because if we're going to reach equity, it's not going to happen because we want it to. It's going to happen because we're going to work twice as hard to get there. The other thing I just want to note is that if we are to combat variants, and we haven't talked really about variants yet, but if we're going to combat variants, you have to have the vaccine reach the places where the virus is replicating. If it's replicating in hardest hit communities, the vaccine has to reach there or you're going to get variants. And so it is our response. It's not even our responsibility because it's the right thing to do. It's scientifically proper also to decrease the amount of virus that's replicating.
I recently had someone phrase it to me in the context that sort of reaching the folks who are most vulnerable is like, yes, the correct public health approach, right? And it sounds like that's sort of what you're saying as well, that this really isn't a negotiable option going forward.
Exactly.
The variants do take me also to sort of the other thing that has been on the minds of so many of, especially our audience, right, which is the question of schools. And I know the CDC has spent so much time on this issue. I'm sure you're tired of talking about it. But I guess what I'm wondering is, I mean, cases, as we saw just recently, they are plateauing, it seems, at really high levels. And I know the guidelines were put out at the end of February, but are we going to have to revisit those reopening guidelines? And what practically will the country have to look like for us to actually see, right, kids of all ages in school 5 days a week, and in-person school, that is?
Right. We spent a lot of time on this guidance, and we're always looking and revisiting the science that leads to this guidance. The guidance was intended to be sort of a document that we could update, but not necessarily intended to be one where we had to shift from the prevalence, right? Because we have all these different levels of disease, and so we really walk through what we believe to be possible with the current level of the evidence, given the disease out there now. The problem, Shafali, is that there's still a lot of disease out there. I think the biggest problem was that it was so very bad at the end of January. 200,000 and 300,000 cases a day, extraordinarily high case numbers, extraordinarily high death rates. That even though we're at a quarter of that, and people are like, have had enough of this already, that feels like now is the time to sort of liberalize what we've been doing. And in fact, it's not. We are at the peak of where we were over the summer. And it happens to coincide with two critical moments. One where we're really worried about variants taking off, and the other counterbalancing that where we almost have a huge amount of vaccine, right? So what we're really asking people to do is be patient and have the vaccine one win and not the variant one win. The school guidance does give us ways to open schools safely. We are not asking schools to close, or not even suggesting that schools close that have been open safely. What we're saying is, if you have been closed, this is the roadmap to get you to open.
Yeah, I would also just add that it's important as we think about equity to talk about the resources that are necessary in order to really implement the guidance that CDC has put out. And I think that's kind of what you see legislatively being advanced as well. We just have to have, an overdue conversation in our country about how educational resources are not evenly distributed across communities. And if ever, right, it's now, again, for us to try to get ahead of the educational inequities that we know pre-existed. As with all the inequities, the pandemic have been worsened and exacerbated by them. And so it is urgent, right, for all our children, but particularly kids who have been sort of left behind, to be in school, right, and to be in school safely. And so we need to also lift up that resource need and resource conversation.
And maybe just acknowledge that when the kids are in school, all parents suffer, but it's the women parents who suffer more.
Yes. I know we're running short on time, and I have two questions that I really want to get to. And the first is, they're both thinking about the post-COVID world, which, right, is so much on the horizon for us. And I, like so many health reporters before the pandemic, thought a lot about health insurance reform, which we know is an issue that is really important to women, right? The cost of healthcare is such a gendered concern. And I'm wondering, do the two of you see a role for yourself in the debate over health reform once the pandemic is behind us? And more critically, has the past year changed how we think about either a public option or a Medicare for all?
I think this pandemic is going to change a lot of how we think about the cost of healthcare, about access to healthcare, and so I think I would be out way over my skis if I started talking about exactly what healthcare reform looks like. I think we need public health reform. I think we need so many things. I worry about the day where the vaccine will no longer be free. I worry about the day when the vaccine, what about all those people? What about if we need a third booster, what happens then? Who's going to pay for that? So I think there are an extraordinary number of questions that are going to be associated with how this pandemic is going to be paid for, how the future of healthcare is going to be paid for, how the future of public health is going to be paid for, because we are a product of the fact that we did not invest in that. And I think all of those things are going to have to be on the table moving forward.
Yeah, and I would just add to Dr. Walensky's list, right? If we're thinking about how vaccines will be paid for, what about therapies, therapeutics, right? There's sort of all these COVID-19 resources that are just essential tests, right? As well as, of course, PPE, right? As we continue to know what works well, and we need to do that. The therapies and the vaccine. One of the kind of the lesions we had coming into the pandemic was this very unequal access to high quality healthcare. As we talk about things like underlying co-occurring conditions, right? A lot of that reflects really what are holes and gaps in coverage for many in our country. So I think we will have a reckoning with what kind of healthcare looks like moving forward. Agree one of our most proximal lessons to learn is around the public health workforce. This is a commitment the president has made, is to build out a public health jobs corps. The real power and value of community health workers, many of whom are women, and making sure that we ladder for them career potential, right? So this isn't kind of some sort of seasonal occupation or job for them. How do we think about people's careers? And what I always say is, coming out of this, when we center on equity, we have to make sure there are pathways to both educational as well as economic opportunity and promise for people. That is how we move forward into a time of resilience and are better prepared, quite frankly, for the next time.
And I mean, building off of that, which gets to the last question I had for both of you, which is, this obviously, right, was in some ways the big pandemic we'd been hearing warnings about for so long, but it seems unlikely it would be the last one. And are we prepared for the next pandemic to hit all of us? And what lessons have we learned thinking about equity and disparities that we can apply to future pandemic preparation and response?
I'm an infectious disease doc, so maybe I will say, in the last 20 years, we've had anthrax, we've had Ebola, we've had H1N1, we've had Zika, we've had COVID. There's probably others I'm not even thinking of. We had SARS. We didn't pay attention to SARS. This is not the last. It's the reason that you have a whole future cadre of people who are interested in infectious disease, because it changes all the time and it's global. And so if we can't learn now the lesson of the importance of investing in public health, then shame on us.
Yeah. 100%. And this question is, we have to. I mean, we have to learn. We have to be prepared. I think the CDC is doing just amazing in a short period of time, thinking about all the important infrastructure that needs to be in place. Even if we think about things like genomic surveillance for the variants, I mean, there's just a lot that's already been done that is going to be there for future as well. Specific to the question of where do we go in terms of equity, it is my deep honor, and I'm humbled to be serving as chair of the COVID-19 Health Equity Task Force. The president has charged this group to come together and to make recommendations about response, really importantly, recovery, and all the next times, right? That we won't have to have this predictability that has become just tiresome for so many of us, to know exactly where, which communities and who will be hit the hardest. We have to disrupt that predictability. That's going to be the work of the task force.
All right, well, thank you both so much. I've learned a lot from this conversation. I'm really grateful to have had it. Have I not asked you anything that you think we should have discussed or that you want the audience to know?
Maybe I will just say to sort of personally commit to what Dr. Nunez-Smith and I have committed to ensure, I mean, we are our best communicators for other people. We can send the message. I have people sort of wearing a sticker, I got vaccinated, wearing a wristband, I got vaccinated, having a conversation, did you get vaccinated? I think we should be having these conversations. We should be the ambassadors of this message in our own communities. Your voices are loud. And then to redouble your efforts and commit and think through how we can help our neighbor, either by becoming a public health official in some way, shape, or form yourself, being a contact tracer, doing something, giving of yourself towards this pandemic and towards the future of our public health.
Absolutely. I want to just thank people for what they're doing and double down on that. It's a call to action, right? Your voice is power. Use it, right? Use it in policy spaces. Use it to be kind to your neighbors, right? Use it to inform your friends, your family, right? Your community about what we need to do so we all benefit from scientific discovery, right? That we all make it to the other side of this pandemic. So just with gratitude, right? And hope and optimism and light. Be well.
Thank you, Dr. Walensky, Dr. Nunez-Smith, and Shefali for kicking us off with that important conversation. This time last year, the nation was focused on getting COVID tests. Now, millions of Americans are trying to get vaccinated. For our next conversation, we are turning to Alaska, which leads the nation in per capita vaccination rates, despite a vast rural terrain. Here to talk about Alaska's vaccination rollout and what the state is doing to serve Native communities are Alaska Republican Senator Lisa Murkowski and Dr. Zink, the state's chief medical officer. The 19th's Washington correspondent, Amanda Becker, will be leading this conversation. Amanda, over to you.
Thank you, Amanda. I'm thrilled to have Senator Murkowski here and Dr. Zink to talk about the COVID-19 crisis and the response in the state of Alaska. Welcome, Senator, and welcome, Dr. Zink.
Thank you. Good to be with you, Amanda.
I wanted to start off with just a statistic that really struck me when I was preparing for this conversation, and that is that Alaska has the highest per capita vaccination rate of any state in the country as of late last week. I was looking at the Bloomberg tracker, and it said that 37 doses have been given out for every 100 people. And I know Dr. Zink has some additional detail about that. So I wanted to hear about that from her, and then just have you both talk about how the state has managed this, given, it's so vast and so rural. Kind of what were the factors that went into creating a situation where we're seeing these great statistics coming out of Alaska?
So yeah, we're really excited to have vaccine in the state of Alaska, kind of like the sun. We had a little bit at first, and now it is coming in quickly, and we are really excited to be on the offense, getting sun in, getting vaccine in, and being able to move forward. We have some communities where over 50% of the community is fully vaccinated who are eligible. We have over 63% of our seniors have started their vaccine journey, and we expect to really be moving quite quickly this next month. Alaska's huge. It's bigger than California, Texas, and Montana combined. You take us and spread us across the United States, and we essentially go coast to coast. And the reason we've been able to get vaccine out to every part of the state as quickly as possible is because of the three major reasons. One has been public health infrastructure. We have a pretty centralized public health infrastructure that has all of these different branches, and we work very closely with the tribes, and public health is tribal health in this state. They are incredibly intertwined. Over 50% of our testing sites are at tribal health sites. And so we built our entire vaccine team in partnership with our tribal team at every single level, from communication to planning to operation. They have been at the table with us and planning. We've also been in the process for redistribution of vaccine for years. We can't get vaccine to all of our communities without redistributing. And so we really built on that existing infrastructure. And it's just re-emphasized to me the importance of investment in public health so that we can be able to respond quickly, and importance with partnerships. So really partnering again with the tribes, but then also the local communities. Again, this pandemic, when communities have the tools that they need to protect themselves and to respond, they get it done in all sorts of creative ways. And so the partnerships with our communities have just been awe-inspiring to see their response and being able to do everything from home to boat up, to dog sled, to snow machine, to plane vaccine allocation and distribution around the state. And then the last big thing has just been creativity and along those partnerships. So we asked for monthly allocation that has allowed us to overcome some of our geographic barriers. And we also know that there's other vaccine coming in for IHS distribution. We have 229 sovereign tribes in our state, and working with them is critical, and they have a vaccine distribution. So again, working with that partnership. But then we're also lucky to have the highest per capita veterans population. And so working with the VA, the DoD, the federal pharmacy partnerships and getting vaccine out in those ways has helped to get our vaccine out quickly and get a lot of people protected. We're really all in this together.
Well, Dr. Zink speaks about the creativity. And before I tell a little story there, I just want to give a very, very big shout out to her and her leadership throughout this COVID pandemic. She has led a team that is pretty exceptional, but I think it has been an energy that comes from her that has allowed us to really be able to tell a pretty strong story about how, in a geographically challenged way, when you've got such large geography and small population, how you do it. There was actually a story, I was looking to see when it came out. It was mid-January, and Good Morning America did a little bit of an interview about what was going on in Alaska and how we were getting the vaccine distributed. And it tells the story of one pharmacist, one medical doctor, and two nurses who travel in one day by plane, sled, and snowmobile to deliver the vaccine to people. They kind of talk about the story of how, in order to keep the vaccine at the right temperature, it's wrapped in kind of a bubble wrap protective envelope, but then literally placed under somebody's arm inside your parka as you are on the sled being hauled by the snow machine, going from the airstrip into town to vaccinate one elder in her home. So the length and the extent to which Alaskans kind of came together to say, we've got to get this vaccine out, this life-saving vaccine. There are far too many, particularly in our small native villages, that remember the devastating impact from the 1918 Spanish influenza and how it literally wiped out whole villages. So getting this out and getting it to the people in these very remote areas has been a challenge. But whether it's literally by small plane, snow machine, or boat, the men and women that have been working to deliver these vaccines have been viewed as the heroes. And I think we're seeing, again, good results in our state right now.
This just seems like a massive amount and an impressive amount of coordination that other states could potentially learn from. I was wondering, why do you think that Alaskans have been able to do this? Is it because in the past, being as rural and as removed as you are from the rest of the states, you've already had to do this sort of coordination, for example, for just the seasonal flu vaccine or something like that? How were you able to mobilize so quickly with this amount of and this level of coordination?
I'll let Dr. Zink speak to, whether it's that public health architecture infrastructure that we have that has really helped. But I think the first point to your question is, we've always been challenged by our geography. We've always been challenged by the elements. We've always been challenged by the fact that it's small population, high cost. So we've had to figure stuff out. We've just had to figure stuff out. And so how we do it may be very unconventional. It might not be delivered in a manner that the CDC would say in their guidebooks is the approved way to do it. But you can't let that hold you back. You've got to figure out, how are we going to make this happen? You have weather delays, you have challenges that you just have to accept. And so you have a lot of planning, you have a lot of contingency, and that's how we work as a general rule. And I think you've seen that play out with how the distribution has worked around the states. People have had to be nimble and act quickly, and I think you're seeing that.
Yeah, I would totally echo what the senator is saying. I remember early on with testing, we could not get any swabs because people were really being allocated swabs based on how many cases they had. Well, we just don't have a lot of people and we didn't have a lot of cases. And so we started to manufacture our own swabs really early on in the pandemic. And we didn't have any commercial labs. So we built up our state public health lab that really did the majority of the testing for multiple months because we just could not get testing in other areas. And that really allowed us to weather some of the first initial challenges when testing was so limited. And I think that really comes from, as the senator's point of like, okay, we know no one's going to come for us. So what can we do ourselves to figure this out and how can we build it? I think the other thing besides the public health infrastructure is to kind of build on what the senator talked about the 1918 pandemic. That has been a part of every single conversation I've been a part of in this pandemic response. I remember really early on, we have this huge migratory population that comes up to fish in the summer. And there was a lot of concern about what that looked like last summer when people were coming into really incredibly remote and rural areas and fishing, living in very densely congregate settings in communities with very little healthcare and what that was going to look like for COVID. And I remember Chief Tilden told me the story about his family essentially going to the woods for an entire year during the 1918 pandemic and said, we'll come back in a year and see what that looks like. And came back and their entire community had been devastated with just immense death. Languages were lost, culture was lost. That has affected Alaska Native people for 100 years since then, that this story looms large. In fact, in his region, the hospital is built in the orphanage that came about because of the 1918 pandemic. And I think that story hasn't been forgotten. And I think in a larger cultural context in the US, we have forgotten about the 1918 pandemic, but we are really susceptible to viruses and bacteria. And we've lived in this golden age of antibiotics and vaccines and antivirals, and we have forgotten how susceptible we really truly can be. And so that oral history from Alaska Native people has driven a lot of our response, remembering what worked, what didn't work, and being able to respond moving forward. And then as mentioned, that infrastructure that has been set up, and we talked about the redistribution. Many times I have no idea how they actually got it out. In fact, the story that the senator shared, I found out about on a Facebook group of physicians where she just posted, I wanted to share what an amazing day today was for me. And all the other group was like, wow, it's really cool. Tell us more. And I asked her if I could share it on social media, and then it took off from there. And so it's just, that's been happening in all sorts of venues all across the state every single day. And it's just Alaskans figuring it out with the tools and resources they have. So we're just really grateful that we have a vaccine that we can distribute, and people are figuring it out in all sorts of super creative, compassionate ways that are appropriate to the community, because we need to continue to build up vaccine confidence, and that's going to come from different trusted messengers in different areas for different reasons. And I think when we really rely on open, honest communication, two-way conversation, and trusting data and science, it really helps. We've been having community conversations with Alaskans since the very beginning of this pandemic. We've had over 400 Zoom meetings where we, share a public science cycle that happens every Wednesday, and people can ask any question they want with our whole team. And we really just want to encourage that two-way communication. So I think that's the other thing that has really helped. We built a structure of communication and transparency since the beginning. And so it just was able to pivot when it came to vaccines.
You've both brought up the Alaskan Native population in the state. It's my understanding that it approaches about 1/5 of all of the people living in Alaska, the Alaskan Native population. Now, we have seen Native American communities in other areas of the country that were really hit disproportionately hard during this pandemic for a variety of reasons that range from not having healthcare available on tribal lands to the same extent it is elsewhere in a state. Not having, mailing addresses to get information to them. Have you seen a disproportionate impact on the Alaskan Native communities in Alaska, or have some of these steps helped to mitigate that as the pandemic has gone on?
We have seen a disproportionate burden of both cases, hospitalizations, and deaths. We really surged mid-November, and that's really where we saw it really started to rear its head. Early on, we didn't, and now we are starting to see really our Alaska Native people, the cases are coming down faster than other races and ethnicities in our state overall, and I think because of the high vaccine uptake amongst our Alaska Native population. Once it got settled in some of our really remote rural regions, particularly like the YK Delta, it became very hard to slow the spread. Multi-generational houses, We have a lot of communities, like in that region particularly, that don't have running water and sewer in their community. And we have seen again and again with other respiratory illnesses, higher rates of disease, higher rates of disease burden. We have a big TB outbreak going on right now. We have 5 times the TB in the state compared to nationwide. So we did see disparities there, and I think it's multifactorial, but unfortunately, we're starting to see that trend reverse in the setting of vaccine.
I think in order to compensate, as Dr. Zink has said, you have overcrowding. You have many villages, far too many villages that lack basic water and sanitation. So if the health advisory is wash your hands, keep yourself clean, and you don't have the water to do that, to provide for your family and to keep them clean, it's pretty tough. When you are in a 3-bedroom house and you have 15 people that are living in that sharing all the sleeping spaces, there is no way for that physical separation. And so knowing how susceptible and how vulnerable and what the history had showed previously with the 1912 influenza, the effort within these rural communities to completely close themselves off. Now, remember, these are in areas, as Dr. Zink says, particularly in the Southwest area, you have small village communities that are not accessible by road. You have to fly in by a small airplane, or during the wintertime, you might be able to take snow machine or dog sled. In the summer, you might be able to go up by riverboat, but there's not a road to the neighboring village. And so when you could say, well, you really do, you just kind of are isolated and you just hunker down on your own. But think about the very specific example of the community of Tuluksak. About a month ago, Tuluksak had a fire in their washateria, which is basically the bathhouse where you wash your clothes, you wash your bodies, and it's part of the water treatment center. Well, all of a sudden, the community of Tuluksak had no water. It's the river is frozen, and the river has high levels of naturally occurring minerals, including arsenic, so they can't just go take the ice from the river. They couldn't go to the neighboring village, which was 20 miles away by snow machine, and try to bring water back, because not only their village was in self-imposed isolation, but the next village over was. And so think about what that means from a health safety perspective, where you want to try to keep the virus out. And so you will say no to outside assistance. You will say there were some villages that didn't even want the mail plane to come in and land and deliver the mail, because they were fearful that somebody would have been exposed and bring it into the village. So extreme measures were taken into place early on to keep these communities safe. And they did. In many of them, they escaped the transmission of the virus. But other things then have presented themselves. Think about what happens when you are locked in your home in a long, cold Alaskan winter. There's no school, there's nothing outside. We are seeing disturbing, concerning matters related to domestic violence, child sexual assault, substance abuse, as people have felt just trapped in their own homes. So these are some of the issues that, as we think about getting on the other side of COVID and what that means, we're going to be dealing with some of this, whether it's, again, substance abuse, the issues of domestic violence. We've seen higher rates of suicide. These are yet follow-ons to the devastation that we've already seen with COVID.
I'm glad you brought that up, Senator. It's something I wanted to ask about, just because you have such a track record of passing legislation, championing legislation that helps protect Alaskan Native women and Native American women elsewhere. You gave a floor speech last year ahead of some legislation that you worked on, where you noted that Alaskan Native women are 2.5 times more likely to be victims of domestic violence. They're disproportionately victims of sex trafficking. Their experience of sexual violence is a lot higher. We have seen that this pandemic has exacerbated domestic violence everywhere, not just in the United States, but in countries elsewhere as well, in Europe. And I was wondering what you've seen on that front in Alaska, if you're tracking it in some way, and if you think there are going to be lingering effects, if that's something that we're going to be continuing to deal with going forward as we emerge from the actual medical crisis, if that might be kind of one of the lingering effects that the state is dealing with.
I do believe it will be. I believe that we are seeing that now, as I mentioned, whether it's suicide, substance abuse, domestic violence, child sexual assault, we're seeing that reflected in the numbers. I maintain pretty close contact with our domestic violence advocates, and they're sharing what they are experiencing in terms of increased numbers and the severity of the domestic violence and the interpersonal violence that they are seeing throughout this pandemic. This past summer, we saw 5 village residents who lived in rural Alaska communities die in domestic violence murders in a 10-day period. Obviously that's the extreme, but it's greatly concerning. The Children's Hospital in Anchorage tells us that they've seen an increase in severe child abuse cases since the pandemic. And you couple this with the fact that throughout this pandemic, those who operate our shelters, our safe houses, the places where these women and their families might go to seek safety, well, the shelters themselves also need to protect themselves from the coronavirus. And so they have had to reduce their capacity in order to prevent the spread. They've got to not have the numbers, and yet the numbers have increased dramatically. And so you have that pressure. You have a reality that we don't have sufficient individuals within our shelters. Because of issues with exposure, you have to have 2 shifts literally, so that one shift can be in quarantine if necessary, because somebody has come into the shelter that has tested positive. So we are looking critically at how this is impacting Alaska, but also more broadly. This is not just an Alaska specific issue. We know that for a fact. So this is something that I've been working with Senator Shaheen from New Hampshire on, trying to ensure that we see COVID relief funding that is directed towards domestic violence survivors, child abuse, sexual violence. But I am concerned that we will see this linger. And it may be that we will actually see it grow in the aftermath of COVID, when we feel like, okay, we're at a good place with vaccines, but some of what has been repressed throughout all of this, as we have been isolated, as we have been in a hunker down mode, as children have not been in school, I think I am worried about what we will see going forward. And the trauma that many will have will carry with them long after COVID is gone.
Dr. Zink, from a public health standpoint, how do you start to address something like this, like an uptick in domestic violence and violence against children? And how are there systems you can put into place if you get federal funds? Like, what sorts of programs can be put into place and infrastructure to help deal with some of this?
Yeah, sometimes I joke that I'm not the chief medical officer of COVID. I'm over public health, and there's a lot more to public health than COVID. And all of these things go together. I also sometimes joke that, the only way that the mind and body are separate is how we pay for healthcare, not in how we actually deliver it. And they're completely intertwined. And so when we don't have running water, people can't wash their hands. If people are isolated, social connection is as important to us as taking a breath, and you can only hold it for so long. And so these things are fundamental to our mental well-being and our physical well-being, be it a long-term care facility, a community. And I think that there are ways to address it For Alaska, it's critical that we're able to braid funds together and that we're able to make it community specific. That is just really, it's really hard to get a sense of what Unalaska looks like if you haven't been in Unalaska. And so if you don't, it's hard to make these federal funds specifically to each one. So flexibility is key so that we can braid different funds together so that we're not just treating one part of each person, but we're treating the whole person and we're treating the whole community to benefit health and wellness. We are looking a lot at the COVID funds currently coming in for testing and for vaccination as essentially seed money on how do we build healthier communities overall. And so if you're going to go to a homeless shelter to help vaccinate, how are you making that a regular process to help build up that homeless shelter? What are you doing for those domestic violence shelters to be able to make sure that they've got the staffing that they need, not only to vaccinate, but to make sure that they, have the staffing that they need for having those rotations? We have run our data in the state. We were fortunate that last year we did not see an uptake in suicides or homicides, but we saw a significant increase in our call lines overall. And I think that it's, again, finding ways to braid that information together, braid together the funding and treating the whole person and not having people work for systems, but systems work for people. And I think we just need to remember that at the end of the day, these are people behind all of these funds, all of these programs. And what way do we make it work for that individual? And that it looks really different. And as states, we need consistent funding in public health. And we also need flexibility to have braided funding so that we can address the whole person.
I would like to talk next about something everyone from coast to coast is talking about right now, and that is schools and reopening schools. And I took a look at the Alaska Smart Start 2020 plan, which for our viewers is kind of their roadmap for schools in different areas that lays out different criteria and metrics that they can use to decide when it's safe and to what extent and how they should approach education. How is that framework working out? What is the overall situation of schools in the state right now? Does it really depend on what area, whether it's more urban or rural? And when do you expect kids to, I guess, be back in school across the board?
It looks very different across our state. So it's really up to the school boards if they're in person or not. One of our school districts for a while was the largest school district on the West Coast to be in session. And they've been really in session through most of the pandemic. Other areas have been out for most of the pandemic and has had a real impact. The Smart Start was started, it was really last year when we were talking about, we need to make sure that education's the constant, COVID is the variable. And so what way do we make sure that education's happening consistently, regardless of kind of case rate and what moves forward? We're definitely looking at changing it moving forward. I think that we have all learned a lot about respiratory illnesses, just how amazingly, honestly, masks can work, the importance of ventilation. Ventilation can be really expensive in Alaska in the winter if you're trying to increase that. So a lot of our rural schools really just don't have the infrastructure to support that or the space to do that. And so kids all really kind of in small, tight areas. So what other ways we can kind of minimize the risk? We've really tried to use geography to our advantage in slowing the spread. We saw when the US would surge, then Alaska would surge a couple weeks later. And when our urban areas surged, it'd be a couple weeks later that a lot of our rural areas would start to pick up on cases. And it really highlighted how interconnected we were, but how at each level we could start to slow down. I also think that schools are public health in most of the communities. Many people know who their principal is. They know who the school board is. They have no idea who the public health person is, and that's fine. And so they are the communicators on what is public health. They teach our kids to wash their hands. They teach our kids about drugs. They teach our kids about how to stay healthy. They teach parents about that. And so they're really a powerful tool from everything from smoking cessation to weight loss to exercise to COVID mitigation. And I think in general, our health teams and our school teams need to be much more integrated in the future so that, again, we're really all trying to make our communities healthy and well because they are the leaders in so many of our communities moving forward. And in fact, some of our rural communities, their Smart Start guidelines was then used by the fishing industry to decide how they were going to do testing. They were the ones who were the most involved and knew the most about what was happening in their community. That then they were kind of this, base point for everyone else in that region on what they should do for COVID mitigation. So that connection to schools here has been huge. But Senator, I know you spent a lot of time on this too.
Well, and I appreciate the fact, Dr. Zink, that you started off by talking about the geography. I think it's important to remind people that you overlay the state of Alaska on top of the lower 48 and we'll stretch from Florida all the way up to California and go from the Gulf of Mexico practically up to the Canadian border. Now, granted, it's not one solid mass, but you have to put this into perspective because you would never suggest that a a school in Florida, for instance, that is in an area where they didn't have much in terms of outbreak, and a school in California need to be on the same school opening schedule. Nobody would suggest that. And so I think it is important to recognize that the way the state of Alaska advanced this was recognize that within the respective school districts, they worked very well. And I think they worked hard to understand the situation on the ground within their region. They are using the best available information. I mean, truly information that was made available not only daily, but even more so. And so really allowing for that to be fashioned in a regional way that made sense. It was not without bumps. We all recognize that. I think we all want to see our kids return to school, but we all want to see our kids return to school in a safe way. And so I know there is just so much focus right now on we have to get the kids back into school. We have to make sure that kids' education continues, right? That should be priority number one. And so in certain areas, it has been more challenging to get the kids back into the classroom. So if they're still able to get that virtual learning, that's important, that's good. But taking you back to Alaska 101 and some of the challenges that we face, we might have access to internet out in Unalaska Dutch Harbor area, but not enough to sustain every kid who needs to be online, not enough to sustain the individuals that are trying to do their work remotely. And so you don't have the ability to provide for the education in some of these areas. Or if you do have the internet, one of the stories from just a couple of days ago was family up in Utqiagvik, which is Barrow, top of the state of Alaska there. Their internet bill for the month, just to support a couple kids that are online and a parent who's teleworking, $800 a month for your internet only. That's just one of your bills there. And so it's not practical, it's not doable. It leaves our kids in a situation where they're not only not in school, but they're not able to get learning in another way, in another capacity. So as we think about those bright lights that COVID has really shown on whether it's our public health infrastructure, one thing that we recognize is key to that infrastructure is broadband and the capacity to be linked in, whether it is through telehealth or distance learning with education. That level of equity is so important for us going forward. So I think we all want to get kids back in school because, again, to Dr. Zink's point about the social interaction, it's key. It's key to us as adults. It's absolutely critical for kids, for young children. And so knowing how important that is just to the human spirit, in addition to what we're doing to try to grow these young minds. We know we want to get the kids in, but we know we must keep not only the kids safe, but their teachers, the administrators, the support staff. So we're making some good headway, but going back to the whole point of this conversation, the more that we can get vaccinated, the more that we can have this level of certainty, the healthier it's going to be for our kids.
Well, thank you so much, Dr. Zink, Senator Murkowski. We were thrilled to have you join us for this conversation today. So we really appreciate it. And Senator, I look forward to seeing you back on the Hill once I get my own vaccine. So thank you so much for joining us today.
Thank you. Thank you, Dr. Zink.
Thank you, Amanda, Senator Murkowski, and Dr. Zink for that terrific dialogue. And now we have a conversation from our founding sponsor, 3M. Please welcome Mose DePool, Executive Vice President of the Healthcare Business Group, Omar Vargas, Vice President of Global Government Affairs, and Melissa E. Clark, Consultant of Physician Clinical Transformation.
At 3M Healthcare, we strive to improve every life by advancing healthcare delivery and innovating life science solutions. Science is a fundamental strength of our company and is core to how we enhance and contribute to the healthcare sector. Our healthcare solutions span the entire continuum of care, from our leading negative pressure wound therapy and surgical incision management technologies to our comprehensive line of skin and advanced wound care solutions. We're focused on helping our customers provide the best care for their patients, aiming at the best possible outcomes.
We have partnered with the federal government from the early days of the pandemic to ensure that respiratory protection, most importantly the N95, has been distributed to where it is needed the most.
We're working alongside biopharmaceutical companies, utilizing 3M filtration technologies to develop and manufacture life-saving vaccines and therapeutics to combat COVID-19. Our innovative technologies, data analytics capabilities, state-of-the-art manufacturing, and experience in pandemic response have enabled us to make critical contributions to support healthcare workers throughout the pandemic. We are well aware that beating the pandemic needs a holistic response.
Healthcare is where all the inequities of society show up. Education, transportation, employment opportunities, nutrition access, even broadband access, and housing instability. 80% of Black and Brown people work in communities or in jobs where they don't have the luxury of working from home. So those professions have extraordinary exposure to COVID. Then there are gaps in availability of PPE, and those are more acute and underserved in communities of color. And then there are also health care delivery disparities. So we saw testing deserts pretty early on where it was hard to get a test for COVID. Where I sit as a physician, I see the urgency of need. I think it's important to treat healthcare disparities as the national emergency that it is.
A recommendation we have at 3M to address racial inequalities in healthcare access is data. Most importantly, patient data.
3M health information systems help to address the unequal effects of healthcare access using science-based, data-driven approaches. They really help you to understand how medically complex different patients are, and therefore how their resource needs might differ.
This technology can help identify those that are at highest risk of poor health outcomes if they were to contract COVID-19, and then place them at a priority level for outreach, PPE distribution, or vaccine administration.
It's also really important to partner with and support community-based organizations like faith institutions, for example, who already have the trust of the community. I'm really proud of the work that 3M is doing in the community on multiple fronts. When it comes to 3M's philanthropy, we can see it in relationship to initiatives with historically Black colleges and universities, with their funding of anti-racism initiatives. And then, in addition, they also give direct product donations, as well as encouraging us as employees to be involved in our local communities.
Building defenses against COVID-19 is a team effort. As a healthcare business, we are passionate about doing all we can to address healthcare disparities.
All of us have a responsibility to fight the COVID-19 pandemic. First, support the President's 100-day mask challenge. We should all be wearing a face covering. Number 2, wash your hands. Number 3, maintain social distancing.
Once a government authorized COVID-19 vaccine becomes available to you, no matter which one it is, we encourage you to get vaccinated. The solution of these problems, I think that we will really be able to move the needle on a lot of the ingrained issues that we've struggled for such a long time when it comes to healthcare disparities, and really move to where we want to be, which is health equity.
Melissa, Mozda, Omar, thank you for that, and for helping make critical conversations on gender, politics, and policy possible through the 19th Represents. Next, I am beyond excited to introduce a performance so fitting for the brave frontline healthcare workers who have been a lifeline to the nation over the last year. It is my great pleasure to welcome Grammy Award-winning singer-songwriter, Sara Bareilles. Let's enjoy this special performance.
Hi, I'm Sara Bareilles, and I am so pleased and grateful to be joining the 19th tonight to celebrate and say thank you to our frontline workers and our vaccine researchers who have worked so hard to help us all weather the COVID-19 pandemic. Words cannot express the gratitude that we all feel to your heroic efforts to help us all get through this. So I will attempt to say thank you with a song. This is dedicated to you. You can be amazing, you can turn a phrase into a weapon or a drug. You can be the outcast or be the backlash of somebody's lack of love. Or you can start speaking up. Nothing's gonna hurt you the way the words do, and they settle beneath your skin, kept on the inside and no sunlight, sometimes a shadow. I wonder what would happen if you say what you want to say and let the words fall out. Honestly, I want to see you be brave with what you want to say and let the words fall out. Honestly, I want to see you be brave, want to see you. Just wanna see you, I wanna see you, I wanna see you be brave, I wanna see you, just wanna see you, I wanna see you, I wanna see you be brave. Everybody's been there, everybody's been stared down by the enemy, fallen for the fears and done some disappearing, bow down to the mighty, but don't run, and stop holding your tongue. Maybe there's a way out of the cage where you live. Maybe one of these days you can let the light in and show me how big your brave is. Say what you wanna say.
That was absolutely breathtaking. Thank you so much, Sara. Now, for our first panel discussion of the day. How do we combat misinformation and disinformation we are seeing about COVID vaccines? We've all seen it on our social media feeds and in our inboxes. What is being done to get Americans timely and accurate information? And how do we build trust to make sure our most vulnerable populations are getting vaccinated? Here to discuss these very important issues are Evelyn Perez-Verdilla, CEO of We Are Mas, Dr. Angela Rasmussen, a virologist with the Georgetown Center for Global Health Science and Security, Dr. Amanda P. Williams, an OBGYN and maternity director of Kaiser Permanente, Northern California, and Dr. Seema Yasmin, a doctor and disease disinformation expert at Stanford University. Leading this panel discussion is Jessica Malady Rivera of the COVID Project. Jessica, over to you.
Hey, thank you. Welcome, everybody. I am so excited to have this conversation with so many familiar faces, and we've got a lot to cover in just 40 minutes. So I'm going to jump right in and ask Dr. Yasmin, you have recently published a book entitled Viral BS, Medical Myths and Why We Fall for Them, which is quite timely given the fact that we are navigating both outbreaks of a virus and a lot of infodemics as well. Can you tell us about the process of writing this book and what you've learned from it?
Sure. So I actually started writing the book about 5 or 6 years ago, Jessica, not knowing it would come out during a viral pandemic and a misinfodemic. But at that time, I was a health and science reporter at the Dallas Morning News. And what happened was, in addition to my daily reporting, whether it was like feature stories or breaking news, I was just bombarded with reader questions about things that were related to health and science, but weren't necessarily in the news. People were wondering about certain vaccines. They were wondering about vitamin D, always wondering about vitamin D and omega-3 fatty acids, chemtrails, all these things. So I started basically a kind of misinformation column called Debunked. And what I would do is I'd take like the most urgent or most interesting questions I got and really kind of do a deep dive into where even did this myth about health and science originate. And then it really got into thinking about why do we believe the things that we believe. But one of the things that I learned was that so much of the questioning and the misinformation and disinformation around health and science had to do with way more than health and science. And it was frustrating to me that from our public health perspective, oftentimes we try and counter information with just more information, really with a focus on the science, when actually what I have seen happening over the last 6 years of tracking anti-vaccine movements and messaging with the misinformation and the disinformation out there, it's about so much more than what's inside the vial of vaccine. So for sure, there's always been the vaccines are toxic, vaccines cause autism. Those are not true, but those falsehoods persist. And yet what we also see is messaging that spreads online that says, vaccines are in opposition to the American way of life. If you get vaccinated, it means you are anti-freedom, you are anti-American. And I think it's really important for us to bear that in mind and realize that we can't just counter these falsehoods with science when that's an important part of it. But one, science literacy is really an issue, or illiteracy. And then there are such deep cultural, religious, geographic, historical context to what the public believes about health and science. And I think we do people a disservice when we ignore those.
Yeah, it's true. I've noticed, that so many things, the conspiracies and the theories in general are kind of copy paste from an anti-vax playbook, which brings me to my next question for Dr. Williams. As a practicing physician, you have had a wonderful background of scientific training, medical training, and you understand the value of consensus. But it seems like vaccine misinformation is especially targeting pregnant and lactating people right now. So as a physician seeing patients during a pandemic, can you tell us any themes or misconceptions, specific fears that you've identified with your patients?
Well, Jessica, this is a patient population that is vulnerable to begin with.
Yeah.
That is incredibly anxious to begin with, especially when you think about first-time parents. I mean, for anyone who's ever been a parent before, that one bouncy seat that you had to have that was so important, or if you put your baby to sleep in this position, then baby will never, get better, never sleep well. This is a preyed upon group. And if we can get back to the why. Why does that anxiety exist? Where are people getting their information? If we don't have something trusted to point to on one hand, and if we are not thinking about the why behind the anxiety, then we see patients really having a hard time. And we're in this pandemic, and in the pandemic to begin with, we're in uncharted territory. So you take a population that is vulnerable, a group of people who are terrified of damaging their gestating fetus, and then feed them misinformation or disinformation on top of it. And I have entire visits that I'm spending just discussing the anxiety, and now discussing anxiety around vaccine. I think one of the places where patients have a hard time is that they are comparing having the vaccine in pregnancy or while lactating to doing nothing. And that's not the appropriate comparison. The appropriate comparison is to COVID in pregnancy, to COVID while lactating. And we know that COVID in pregnancy does have worse outcomes, does have increased rates of hospitalization, of being in the intensive care unit, of preeclampsia, of C-sections. So these various pregnancy outcomes that patients are trying to avoid are more likely to occur if they have COVID. So thinking about the individual patient risk, and getting patients to think about the comparison group, and then what's behind the anxiety, what is the fear, and then validating patients' fears and the unknown, especially because the vaccines weren't studied in pregnant and lactating people, really has been a more effective strategy than just bombarding them with more papers and the best written information that we can find.
Right, right. And so that actually brings up the topic of kind of being a trusted messenger, and medical mistrust, which we've noticed is an issue, a legitimate issue in many communities. So I want to present this question to the group. What can the medical community and even public health professionals do to ensure that the messengers of this information are trustworthy, particularly among communities of color with legitimate concerns in light of historical trauma?
I think there's a lesson perhaps to be learned from what's happening in journalism, where you see some outlets, Nat Geo, the Los Angeles Times, saying, hands up, we're going to start acknowledging and atoning for our racist past and our role in perpetuating white supremacy. And the reason that makes me think about medicine is because we have an equally or perhaps even more sordid history of exploiting vulnerable people and exploiting enslaved people, for example. And yet I don't think we've ever had those conversations or that reckoning. Our medical school lecture theatres are still named after eugenicists and fascists, right? And yet what we do in the middle of a crisis is say, trust us, here's a vaccine. Oh, why aren't you rolling up your sleeve? Oh, look, Black people, so vaccine hesitant. Like, that's become the conversation. And so I think we have to wash our dirty laundry very publicly. I think we need to understand and say why these communities don't trust us and talk about our role in that, and also not just framing it as a historical issue, because we have data about medical racism being very, very much a modern, current day problem. So I think that would play some small role, or perhaps a really important role in building those bridges.
And every time I speak, coach my colleagues, that is where I begin. You do not deserve the trust. Yeah. Your white coat does not buy you trust from your patients. And so by acknowledging first, not just historical, but current day health disparities, racism in medicine, it's easy in the maternal health world because we know 3 to 4 times risk of death with Black women compared to their white counterparts exists. So we have to start with humility first and let patients know, look, this is going on and you have no reason to trust me and to trust this scientific medical complex. But please, over time, I hope that I can earn your trust That sort of perspective, I think patients really align with much more than the, well, what's wrong with you that you don't want this vaccine that can help save these communities that have been disproportionately impacted by COVID.
Right, right.
Yeah, I would like to add to that because that's one of the specific issues with our Latino communities or communities of color is that they have been deceived before.
Yeah.
And being that they have been deceived before, you know, right now, the trust not only has to be in collaboration, the trust has to be in really going to the local leaders, to the people who live in these communities and the people that they listen to, their doctors, and giving them information. One of the biggest issues right now that many people talk about is that they don't have information. They don't know where to look for it. And due to that, that's why we have these QAnon channels in Spanish that are, the disinformation is going high, and I can give some numbers later, but the fact is that there's a space now for information that these individuals, these people are looking for. Our communities are looking for it. So we have a lot of work to do in collaboration with the communities.
Yeah, this is actually, it feeds right into the next question I had, which was for you, Evelyn. As a journalist, you've seen so many kind of clickbaity and panic-inducing headlines. What does trust mean on the journalistic side of communicating things about science and health?
Well, once again, trust means collaboration. And it's also been great to have journalists. It's great to have journalism, especially in the times that we live in right now, where many in our communities are told that the media are the enemy of the people, right? And that is something very big. That's the reason why I started looking more into this disinformation, because we were sounding the alarms of the disinformation we're seeing in these private WhatsApp channels. And it took for a journalist from Politico to write a story that brought journalists from all over the world to look at these private WhatsApp channels in Spanish. Right now, I spoke actually to the adjunct director of the fact-checking network for Pointer Institute, Cristina Tardaguila. And she was mentioning one of the things, once again, in collaboration, is that they have a coronavirus facts alliance database. It's the largest fact-checking collaboration project in history. It has 99 fact-checking organizations. It has 70 countries fact-checking in over 40 languages. And what they are saying is that they have found 12,000 falsehoods, this is borderless, in more than 60 countries in 43 languages. And what they're seeing is that 80% right now of the content in February was about vaccines. There are other things, but vaccines is what's coming up right now and is creating this distrust in the communities.
Yeah. Dr. Rasmussen, you've been debunking a lot of vaccine misinformation and a lot of just bad takes on virology, which is your expertise, on places like Twitter. I'm curious if you've observed kind of the why, the reasons why you think people believe and or spread misinformation.
No, I think that's a really great question. It's also a really complicated one because there's not just one answer as to why. I think that a lot of people, as Evelyn was just saying, are getting information from unreliable sources. Now, whether that's a group in which misinformation is being distributed, whether that's just hearing from people that they know who might have an opinion one way or the other about vaccines in general. And some people are actively seeking out misinformation. They're very susceptible to the tactics that anti-vax groups used intentionally to distribute misinformation among people who are looking for information but might not know where to get good information. I think also there's certainly a general distrust of scientists and physicians and people who are part of the medical community, people who are part of the public health community. And in part, I think that's because of the way that the pandemic has gone. People have seen over and over again public health agencies making mistakes. I mean, in the US, certainly the Trump administration actively tried to undercut the CDC. And so it's completely understandable when you have somebody like Tony Fauci, who for decades has been a reliable source of scientific information is now this hugely polarizing figure. Things like masks and public health measures have become very polarized as well, and they're still polarizing topics. And I think a lot of people, based on their own personal beliefs, are kind of falling on one side of that to the other. Public health is the casualty that is sort of left behind, and public health is gained. Trust in public health is gained in drops and lost in buckets. And it's just going to take a long time to get those drops back that we've lost.
Absolutely. I want to pose a question to the group. We've started to see that misinformation and disinformation has become even more targeted. Personally, and going after groups such as, pregnant and lactating people, racial groups, ethnic groups, religious groups, and even gender. So what are ways that we can support and empower these communities to fight back against these campaigns that are so deeply targeted against them?
I would say it's not a new phenomenon at all, Jessica. And in fact, when I've been teaching public health comms over the years, I say to people, let's take a page out of the anti-vaccine playbook, because one of the things they do really, really well that we don't do well in public health, and I don't think in the medical establishment either, is that hyper-localized targeted messaging. And in the book, I write about the horrific outbreak of measles that happened among the Somali community in the Minneapolis area. It was the worst measles outbreak in that state's history for like 3 decades or so. And these kids were hospitalized. It was horrible. And you can trace it back to about 10 years earlier, when the Somali parents were concerned that there were perhaps higher rates of autism amongst their kids compared to white kids. And the public health department said, okay, we'll look into this. And in the meantime, literally Andrew Wakefield arrived in Minneapolis, and other anti-vaccine groups holding these closed door town halls with armed guards outside them, so public health physicians and journalists can't get in. And what they did was really effective, because they said, we heard you're concerned about higher rates of autism among Somali children. You're right, the rates are higher, and it's because you vaccinate so much with MMR. And then what we saw happen over the subsequent years was the vaccination coverage with MMR among Somali kids went from 92% to about 42%. And you think, okay, I mean, it was horrific, but it was also an example, sadly, of effective targeted messaging. And so I do get frustrated that in public health and in science, we often use a one-size-fits-all message approach, and we say, oh, there are these myths about toxicity or about autism. It's just not true, when actually there is a science to science communication, and it really demonstrates that the answer to misinformation is not merely more information. And so I think, sadly, there are lessons to be learned about effective communications, especially hyper-localized, targeted messaging from anti-vaccine groups that have just been doing their job better than we have been doing ours. And it's been going on for decades.
Mm-hmm. We also have to think about who are the trusted messengers, because who we think, the groups that we think are worthy of trust is not necessarily the same group of people that our patients think are worthy of trust. So you can have the Society of Maternal Fetal Medicine put out a great statement, but who's really reading it? And what have these big organizations done to gain trust? So that's why exactly what she was referring to, such as the local folks, the local clinicians, the church leaders, the community group leaders, people in the school systems. That's who we have to engage to be our messengers, because really it's a lot of small conversations. I had a chat with folks when I took my boys to get their hair cut the other day with one of the barbers who's like, absolutely not, I'm no way getting that vaccine. And maybe I didn't change his mind, maybe I did, but at least everyone in that entire barber shop, all 6 feet apart, did hear what I was saying. And perhaps these smaller conversations from people inside the community can start making a dent.
Yeah, I would say I would agree with that completely. I like to use, I work a lot in messaging, and just like the words they use that can create that fear, or, you know, in the QAnon groups, you see a lot of words. The words are, you know, charged. And for me, it's always, you know, they're probably targeting, but our work is to micro-engage. It's to micro-engage to a way that it's not only about culture, It's about the subcultures of those cultures. It's understanding how these communities live. And the only people who know that are the people who are actually coming from those communities. So, I mean, there's a lot of work to do. And it also has to do with the responsibility of having, let's say, the HHS, give information in different languages that can then go to the communities. One of the things I've always said, and I think we all agree on this, we cannot wait for them to search for us. We need to find them. We need to go for them and look for them and give them the information they need.
Mm-hmm.
Yeah. And if I could just add to that too, I'd like to really echo everything everyone has just said about this. I think that the most important thing some of us can do right now is actually not talk, is listen. Because somebody who has questions about the vaccine development process, about the vaccine technology, those are appropriate questions for me to field. But if somebody has a completely different concern about the vaccine that I may not be an expert in, the most important thing I can do is listen to what those concerns are. And if I can't respond to them, have the humility, as Dr. Williams was saying, to direct them to somebody who they do trust, who can address those concerns. I think that there is a real one-size-fits-all problem, as Dr. Yasmin was saying, in which scientists really kind of respond to questions about vaccines with just hammering people over the head with safety and efficacy data, and how this is how the vaccine works, as if that's going to answer everybody's concerns. Many concerns have nothing to do with how vaccines work or the accelerated development pipeline that these vaccines for COVID have gone through. So I think that scientists really need to only address the questions that they are qualified to, and make sure that they are referring people to sources that would be reliable and trustworthy for other concerns.
Yes, that brings me again to, you guys are just feeding these questions in such perfect order. It's amazing. There is a science to science communication. There's strategy in knowing which myths to bust and which ways in which you can address concerns. So Dr. Yasmin, can you tell us about some best practices for scientists and science communicators when it comes to sharing information about very sensitive and delicate topics like vaccines and communities of color?
Yeah, definitely. And this is the thing I do worry about. In the book, I debunk, like, I don't know, some 40 something medical myths and health hoaxes, and there are some truths in there too. But the final chapter is, does debunking a myth help it spread? Because in the communications literature, there is a body of evidence that argues and demonstrates that when you even repeat a myth, just because you want to debunk it, you can be giving it more oxygen and giving it a platform and helping to amplify and accelerate its spread. So I do take that very seriously. And I think the reason I wrote the book, and because the reason I am passionate about still debunking and dissecting misinformation, is because there's also evidence that when it's done appropriately, when it's done well, it can be really, really effective in helping people understand why the information they're dealing with is actually false information. I think those best practices are really contextual and nuanced, and understanding what might be best left alone, what might even not be affecting a particular community that hard. That again comes down to engagement. And I really like the way of thinking about it as micro engagement, not making assumptions about particular communities, but collaborating with stakeholders and community leaders to be like, let me not throw assumptions into this conversation. Because I always say, you talk to 6 people who are vaccine hesitant, who are on the fence about different vaccines, you can get 6 really different responses as to why they've come to feel that way. So the first part has to be community engagement, understanding what really would be of service to the community, and then how do we address those issues. And then I start to worry less and less about just giving a myth more oxygen and more of a platform. But I think it has to be debunked in meaningful ways that make sense to the community. And again, I really believe with comms has to be a hyper-localized community engagement type of approach.
Right. And so, Dr. Rasmussen, can you speak on what do you think the role of non-scientists and even science-adjacent people have on the same question, on the influence, and I'm talking even people with verified accounts, people with large followings, when it comes to public discourse around these sensitive topics, what role can they play?
Well, I think one thing that non-scientists or science-adjacent folks who, may be history experts or sociology experts or psychology experts, you know, who can think about these things, even if they are not experts in necessarily the underlying science or medicine that's being debunked. I think it's really important for people to be very conscious of their platforms and how they relay information to people. We've had a big problem with the quote unquote armchair epidemiologists or sort of tourists in this space who have really kind of jumped onto the COVID communication bandwagon without really thinking very clearly about the consequences of, you know, some of these really hyperbolic tweets like, oh my God, the virus is mutating. Oh my God, the variants, the vaccines aren't going to work anymore, siren emojis and so forth. And, you know, the effect that that has on people is it really doesn't inform them. It doesn't empower them with a better understanding of what's really going on, what the state of the art is in terms of the research and our understanding of this pathogen. It just scares the hell out of them. And then people, I think, are more susceptible to misinformation because they're looking for something that's going to validate their fears and their concerns and these really base emotions that they have. So I think that when people are communicating outside their quote unquote lane, they really do need to be very conscious of how they are sending that message out to people. Make sure they're sending out good information that an expert would look at and say, yeah, that's accurate, rather than, you know, doing something basically to get lots of likes and clicks and follows.
Right. Right. I mean, that makes social media wonderful and terrible for that reason. I mean, it's become a critical social media and chat platforms have been a critical place for good information and bad information. And I know, Evelyn, you've kind of spent some time even infiltrating some of these spaces and kind of identifying some trends that are targeting the Latinx community. Can you tell us about some things that you've seen as trials and triumphs in that work?
Sure. Well, I'm really concerned. I'm concerned because of the level that this is heading within the community, in specifically in the Latino community. When you start seeing QAnon channels with over 5,000 subscribers that are country and culture specific, that focus, like you said, on everything from vaccination to political ideologies, from denigrating our current leaders to uplifting people like our former president, all in one day, continuous and repetitive, you have concerns because you realize that the $1 million question is, you know, who's behind this? Yes, the you know, anti-vaccine has been here for a long time, but there's also, it seems, something with a very strong intention to weaken the democratic institutions and our institutions here in the United States, no matter where the information is in other places in the world. And that concerns me. But I think specifically, I think that if there's something that I see from this is, once again, that we really need some serious research on specific communities, because it's very clear that they have researched us. And they have gone so specific to understand where to connect and building that trust within family and friends and people that they know. I started this seeing, you know, this information in 2018, but when I was invited to a COVID VIP leadership WhatsApp chat with 100 leaders in Florida, that started off with building the trust, and then 2 people in a COVID VIP leadership where they were giving information to our communities of where to get food because they didn't have food to eat. 2 people started infiltrating that group and putting anti-vaccination themes. And that is painful because it's abusing of our communities. It's manipulating them. And that's why for, I think, all of us, it's a deep concern, no matter if we're in science or whatever industry we are, it is deeply concerning that we have to deeply look at this and find a way to reach these communities and make them realize what's really happening.
May I
Yes.
just really add to the back of that, that I totally agree with that. And as a researcher who's been trying to do that localized research in the 5 years, say, before the pandemic, it was so hard to get funding to do exactly that kind of research. And it was even hard, not even just to get funding, but to get buy-in from public health agencies who were really dismissive about the issues of misinformation and disinformation. And they would say things like, oh, but it's not a big issue. Oh, but vaccination coverage rates broadly are okay. And I wonder if perhaps, if it's even okay to say this, but some silver lining of the pandemic might be this realization that, oh, public health misinformation and disinformation really is a threat to national security, as many of us have been saying and trying to get support with for years.
Mhm. Yeah. You know, we've got time for one question. I think this will sum it up really well. And this is for you, Dr. Williams. We've talked about all of the many ways in which vaccine hesitancy is not just one thing. It's everything from distrust to dissent, indifference, and even deliberation and trying to make informed choices. So how can we avoid this issue, this complex issue, which predates COVID-19 from becoming a self-fulfilling prophecy?
Well, I think one of the first things we can do is be mindful of our language, and really think about deliberation, because people should deliberate. It is a good idea, especially communities where there isn't data, like breastfeeding and pregnant people, where it's very just limited cases. And also Black people, and specifically in America, where there are so many different examples, whether it's radiation experiments, syphilis experiments, involuntary sterilizations. We have to own and affirm people in their deliberation. And then have, as I said before, the humility to ask why, why they have concerns, and then see where are they getting their information, point them to reliable sources if that is what the issue is, and then just try to really understand how can we walk with them on this journey. This is not, as was said previously, a one-size-fits-all approach. The more strategic we can be about supporting our communities, the better off we're going to be in terms of getting our America vaccinated, so that we can get out of this pandemic once and for all.
Does anybody else have any thoughts on how we can prevent this self-fulfilling prophecy as we wrap up?
I'll quickly add then that I think this idea that there is science behind science communication, and there's decades of literature from communication scholars, which sadly too many of us in science haven't bothered to read, and it really does demonstrate the importance of narrative. And I got really frustrated with WHO a few years ago when there was a really bad measles outbreak in Romania, and they were like, but don't worry, WHO is disseminating pamphlets. And I was like, dude, it wasn't pamphlets that started this problem. It was these hyperviral, really emotional YouTube videos of people saying and crying with their toddler in their arms saying, my kid got autism from a vaccine, right? You don't counter that with pamphlets with bullet points of facts. And I know we love our facts, but we really need to pay attention to the science of science communication using narrative methods, which are really have been demonstrated to be evidence-based ways of countering the misinformation, disinformation, building trust, and really just giving people the information they need in meaningful ways that can help them make informed decisions about their health.
I totally agree. And I would just end by saying that my challenge to myself, really through this whole pandemic and trying to improve my own ability to communicate with people, is really to listen more. We need to be meeting people where they are. Not everybody actually wants to hear about how an RNA virus replicates. Not everybody wants to hear about how an mRNA vaccine works. Some people want answers to different things. And then on top of that, we need to also have the humility to refer people to other experts outside of our field if that's where their questions lie. I've seen way too many people try to be an epidemiologist, a virologist, an infectious disease physician, a policymaker, all in one. And, you know, we all have our own areas of expertise. They're all important. But we also need to be humble enough to know when we're being asked something that's outside of that expertise, and somebody else might be able to answer the question or address those concerns in a better way. So I'm just going to conclude by saying that my own challenge to myself going forward, that I think will make me personally a better communicator, is just to listen and to check my own appraisal of my own performance.
Yes, absolutely. Evelyn, do you have any last thoughts on this?
No, I love the fact of just very true. Listen, listen, and it's important to realize that this is continuing, and we cannot just ignore it. We cannot laugh it off.
Mhm.
This is going to affect a lot of things if we don't pay attention to it, from the highest people in our nation to the local people. We really need to collaborate together to change the course for our communities to have trust in the vaccination system.
Yes, I completely agree. And I love that you mentioned even just the not laughing. Too much of debunking and demystifying can lean into sarcasm and name calling. And I think that there's a lot of empathy and space for that nuance that's required from all of us. I know that I have benefited from the kind of cultural competence and the empathy in which you all communicate about COVID, and even on this panel. And I'm just really thankful for all of your time today. For those who are watching, I highly recommend following all of these wonderful leaders in this space who do their best to listen and to speak well. Thanks to our panelists for that important discussion. And now, a short word from our presenting sponsor, Pfizer.
When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win.
Next up, we are going behind the story with the 19th's Co Bragg. Co has been reporting on the impacts of COVID-19 on women like Amira Carson Carey, who has been fighting for equitable healthcare for her infant son, Imani. Let's hear from Co and Amira on what it has been like to live through the pandemic and a summer of racial reckoning.
Hi, my name is Co Bragg, and I'm a general assignment reporter at the 19th. I'm really excited to be here with Amira Carson Carey, who is a fellow Mississippian, a Black mama who I've been talking to for months and months and months in the midst of a pandemic, as she had a pandemic, like a COVID baby. I don't know if that's the term we're giving.
Yes.
Yeah, her son Imani turns 1 in April, and through this year where we have been talking about race and equity, particularly around the Black community and what that looks like through your family that has also recovered, thankfully, from COVID-19. And so I just am so excited to get to talk to you and share your story that of resilience, and just that touches on so many things that as a nation that we've really come together on. And so I just would like you to just, tell us a little bit about, how your life changed when you gave birth to Imani last April, and sort of just how quickly things changed when you found out that he had a rare heart condition.
Having a child during COVID was very traumatic. He was my second child, so the whole hospital setting was different. The whole restrictions were different. No one was allowed. My parents weren't allowed there, so it was very different. But having a child, you kind of go through the motions of just being a new mom, and that's what I did until he was about 2 weeks old, and then I started to notice. I just didn't feel right with the way that he was breathing. And thankfully, throughout this entire process, I mentioned a lot when we talk about having that network of medical professionals that I can consult, and they can say, no, we don't necessarily agree with this. That has been the backbone of why I've been able to advocate for my son the way that I have throughout this past year. And that was how we found out about his condition, just not really being comfortable with the way that he was breathing, and, sending videos of him breathing to some of my friends who were medical professionals, and they were being like, yeah, he looks like he's retracting a little bit, but he never, ever showed signs of being in distress. So we weren't really just alarmed. They would just, take him to the ER, they'll examine him. And if it's nothing, you guys can go back home. So, the first week of May, and I believe April, May was when COVID just spiked everywhere. So yeah, we went to the ER. They had like COVID tents, like screening tents everywhere. And they were getting ready to send us back home. They was like, well, no, he's not blue. He's not showing us any signs of distress. So, you guys can just go back home. And if you are anything, if he starts to, like, if his nasals flare, which is the indication of being in distress. So they came back and checked him, and just randomly, his heart rate spiked to about 230, around 230 and 250. So average age range for a newborn is 150, maybe 160, being the highest for a heart rate. So that immediately, sent red flags in. They got his heart rate to come back down, but that's when they called the cardiology team and they did the echocardiogram. And it showed that my son had 5 different heart defects. So yeah, having to hear about your 2-week-old son having, this completely rare heart condition in the ER was incredibly overwhelming. But from that day forward, I had time to kind of sit with it. But from that day forward, it was, what is it going to take to get him the absolute best care that he needs?
So after you find out that he has this rare heart condition that affects 1 in 10,000 children, you have this to keep monitoring his heart while you're looking for a place that will be able to do the surgeries that he'll need to live a full life. Can you just talk about particularly what that process was like as your family also was recovering from COVID that swept through your household, and that ultimately, Imani began to test positive once he arrived at the hospital that you chose?
Yes. So choosing the hospital and the program to do his surgery was difficult because the procedures that he needed, the order that he needed, was just really rare. And a lot of surgeons don't perform the surgery that he needs on babies at the time he was 3 and 4 months old. So he was really, really, really small. So they typically like for children to be, have more weight, more heavier, because that really, and I found that out after the first surgery, that really affects, the more weight they have, it really affects their recovery. So it was really hard trying to find a program. And we were going with a program. I didn't know, I just heard this is the best place for you to go, so you go there. And so at that point, I was thinking, this is the best decision. And then we get COVID. My husband got it first. He was down. Before we found out that's what he had, everyone in the house was exposed to him, the baby included, because he's 2 and 3 months at the time. So when I get it, I called the doctors here, and I was like, he was exclusively breastfeeding at that time. So I was like, am I gonna pass it to him through, So I had to distance myself as much as a 2-month-old exclusively breastfeeding mom could. And I did. I tried. I tried to make sure that he didn't, get it, because I was so afraid. He has this condition. He has these medications that he's taking around the clock. He's on the heart monitor. He wasn't on oxygen at that point. But I was really afraid that if he got COVID, it would be dire. The consequences would be dire. And I was so afraid. I cried so much because I just didn't want him to get it. And I thought that we were in the clear, because we tested positive for COVID around the 25th of June. And we didn't get to the hospital in Houston until a full month later in July. So we get to Houston, we get admitted to the ER. They decide, we're going to go ahead and admit you. So just randomly in the ER, they say, before we send you up, we're going to swab your son. And I'm thinking, oh, there's no, we've tested negative. It's been a month. And we get to the room, and I'm wondering why, the nurses are coming into the room with full PPE on. And I'm like, okay, maybe this is protocol. We're in another state. This is COVID still, very high in Texas. So they say, well, his test comes back positive. And I was completely shattered. How did this happen? Why did it take so long for him to test positive? He's already exhibiting signs of heart failure. How is this going to affect him? How long does this mean we're going to have to put off the surgery that he needs? So there were a lot of questions, and it was very, very difficult. And it actually took him about 2.5 more weeks to test negative. The positive side to that was he showed absolutely no symptoms. He didn't have to be put on a ventilator or anything like that while we were there. We really just had to wait until he tested negative. And it was hard.
Yeah, I feel like your family just kept, getting hit with all of the disasters that we've been wrestling with and hearing stories of as a nation, and just your family it was just successive. And, one of the things, we connected was through your open letter that you had written, really trying to explain to people, to politicians, et cetera, in Mississippi about what you had been through. And, I'm going to read a little bit of it, but, I would love to, now that Imani has been through 2 surgeries successfully, he's gaining weight like, a child his age should. I'm going to read what you wrote, because I think it's really encapsulates sort of what's at the top of mind for a lot of Black mothers in this country, as we have more language to talk about sort of the inequities and the way that intersects with racism. And so we'd love to see him and and I'll read this if you want to grab him. So from your letter, you say that, quote, "I'm aware that disparities exist in healthcare, and I recognize that in many ways, Imani and I are part of a statistic that includes Black mothers that have received poor maternal care and as a result are facing an uphill battle. I now understand what it means to become a medical advocate for Imani and to harness all the resources available to make sure he has access to the best care possible to him. Regardless of my income status, his insurance coverage, or his race, Imani deserves a fighting chance."
Uh-oh.
Hi, Imani.
He was sleeping. So he's a little discombobulated.
I was wondering, oh wow, his cheeks are like
Bless
incredible. I was wondering if you could just share,
and everything.
I know, I love it. I'm wondering if you can share a little bit about how you chose his name. Imani means faith.
Mm-hmm.
And as we talked about, and as we share in your story that's up on the 19th, is that your faith is one of the things that's been tested in this last year of his life and of your life. And so I'm just wondering just sort of what it means to have a baby named Imani, who's almost 1. Yeah.
I don't even know what I was thinking. Like, if I'd have known, naming him that we would have to go through everything that we went through, probably chose something else. Something a little bit more calming, less stressful. I remember looking up, I wanted, there's a big thing in my family for our names to kind of have a cohesive meaning. So I remember looking up names. What's the matter? I remember looking up names. I wanted him to have an African name, but I wanted it to mean something. So I really just Googled like African names and went down like the alphabet. And I made it all the way to I. I didn't see anything that I liked until I got to I, and I saw Imani, and I was like, okay. And I looked up what it meant, and I was like, okay. And my coworker is Algerian, so my first name's Arabic. My son's name, it's a different name, but I was telling her that I liked Sadiq. Raphael Sadiq was my favorite artist, and she was like, that's an Arabic name, and she was telling me the different ways to spell it. And so I asked her what it meant, and she said, honest, noble, and dependable man. So I said, that's it. That's my baby's name, Imani Sadiq. So that's how I came up with his name, just because of what it means. I didn't think it was going to test my faith or test my just overall, drive, will to just persevere. I did not know that that's what it would mean for me, but I wouldn't change it. That whole process. I feel like everything that we've gone through, and I do believe that nothing that we go through is solely for us, but those really difficult moments that we have to experience are just tools to help someone else.
Amir and Imani, thank you so much for joining us. You can read more about their story at the19thnews.org. And I'm so happy that he was able to join us. Sorry for interrupting your nap.
Thank you for having us. It's my pleasure.
Thank you, Ko, and thank you, Amira, for sharing your story and incredible experience with the 19th. We are nearing the end of today's 19th Represents program with a look at how COVID has widened the equity gaps in our healthcare system. Helping us explore the lessons of the last year is Samantha Artiga, Vice President and Director of Racial Equity and Health Policy at the Kaiser Family Foundation. Samantha is joined by Dr. Michelle Nichols, Associate Dean for Clinical Affairs for Morehouse School of Medicine and Medical Director for Morehouse Healthcare, Abigail Echo Hawk, Executive Vice President of the Seattle Indian Health Board and Director of the Urban Indian Health Institute, Dr. Laura Erickson Schroth, Psychiatrist at the Hetrick Martin Institute for LGBTQ+ Youth, and Dr. Ava Galvez, Board Chair of the Migrant Clinicians Network. Samantha, over to you.
Thanks so much, Amanda. One pattern that really has been consistently clear since the onset of the pandemic is that it has taken a much harder toll on some groups and communities than others. The pandemic has really exploited and exacerbated longstanding social and economic inequities, putting certain groups and communities at higher risk of exposure to the virus, experiencing higher rates of illness and death, and facing greater financial challenges to the pandemic. I'd like to start today's conversation by asking each of our panelists to speak to how the pandemic's uneven impacts are really reflective of underlying inequities that were already present among the communities that you serve long before we started dealing with the outcomes of the pandemic. Ms. Echo Hawk, can you start us off?
Absolutely. Thanks for having me. It's so important to think about the fact that this disproportionate impact on communities of color did not start a year ago, didn't start 2 years ago, but for my community, the indigenous peoples of this country, American Indians and Alaska Natives, this started more than 500 years ago. The organization where I'm the executive vice president, the Seattle Indian Health Board, and direct our research institute, the Urban Indian Health Institute, we actually were in Seattle at the center of COVID-19 in February and soon experienced a lack of PPE. We asked our federal, our state, and our local partners for masks and for gowns for our providers. But what we got instead a couple weeks later, we didn't get those PPE supplies. Instead, we got a box of body bags. We're a community health center. We don't even use body bags, but it was such a metaphor and a literal box I saw in front of me of how this country has been treating American Indians and Alaska Natives. When we look at the underlying health conditions that puts our people more at risk for being hospitalized and also for death, we have high rates of obesity, diabetes, cardiovascular disease, and we can trace those back to the first interactions more than 500 years ago of the colonization on this land, and then the non-fulfillment of our treaty and trust responsibilities that have chronically underfunded the Indian healthcare system, which means that our relatives have been receiving substandard care, lack of access to food, lack of access to socioeconomic and educational opportunities that have resulted in these chronic health disparities that are putting our people more at risk during COVID-19. And every single day, every hour, I think of the loved ones I have lost and my community has lost, and I grieve for them because we know this didn't have to happen. If only the United States had actually fulfilled the treaty rights and the responsibilities they have to American Indians and Alaska Natives. These disparities were built, and this pandemic has illustrated when these disparities are built in this way, they are meant to marginalize, they are meant to harm, and we are seeing that harm right now within our communities. And something has to happen, something has to change. We need our policymakers, we need our allies to step forward and say, this is not acceptable. This is not what the first peoples of this United States deserve, and it's not what they were owed.
Thanks so much for sharing that, those thoughts. Dr. Galvez, can you offer some thoughts from your perspective?
Absolutely. And first of all, it's wonderful to be here. Thank you to all for your perspectives. I am a family physician that works at a community health center that has been taking care of primarily Latino patients for years. And I can tell you that we have a very vulnerable population. Even before the pandemic, our patients really suffered from poor health. This was due to language and cultural barriers, unsafe working conditions, lack of healthcare, lack of access to healthcare. And what we saw during the pandemic is that this is a population that suddenly became essential. While most other people had the ability to stay home, many Latinos were forced to leave their home so that our nation could continue to run, so that we could have food on our tables. But unlike many essential workers like myself who had worker protections, who have benefits at work, this has been a group of essential workers that has not been granted the same protections that other essential workers. And this has been going on for years, except that what has changed now is that COVID-19 has unmasked the conditions that this community has been working under. And I can tell you that I have patients that were going to pick berries in July and August in vans, none of them with PPE. Some of them were told they could buy their own PPE. Others were given nothing. And these are the stories that I have been hearing throughout the entire pandemic. People who go to work, they don't have the protections. They're afraid to speak up because they're afraid of retaliation. And then let's also think about the public health guidelines that we give. Stay home if you're sick. You know, if you're a low-wage worker that doesn't have sick leave, staying home for even one day can mean not being able to feed your family. Now, what if you have to quarantine for 2 weeks and you don't have sick leave, or you don't have an employment and you do not qualify for stimulus? This can be financial ruin for many families, which is what we have seen. Low wages also force people to live in multi-generational housing. Families cannot live with a family of 5. We have families that are living, I have families who are living in a small apartment with 10 people. That's actually not bad. Think about the farm workers. You have sometimes 20 people sharing one bathroom. How can you follow public health guidelines when you have these kind of conditions? So these are the conditions that are driving the disparity that we are seeing to COVID, and it has to change. And I can tell you that I am still on the ground talking to my community. Nothing has really changed for this community yet.
Thanks so much. I think that really makes clear how the existing inequities have really placed different communities at different risk throughout the course of this pandemic. And as we start to look ahead also to recovery. Dr. Nichols, have you had similar observations in terms of your experiences and with the communities that you serve?
First of all, I want to thank you for inviting me to speak. We have had very similar experiences. I am the Associate Dean for Clinical Affairs at Morehouse School of Medicine, and also the Medical Director for our clinics. And we've had the same thing. The African American community has been greatly hit by the pandemic, and it stems back to when we were first brought over here to this country. So we have been used for experimentations, as it's seen with the Tuskegee study, as seen with the Henrietta Lack. And so that has led to mistrust within the community as well with people. Also, you have the same multi-generational types of effects. And most times you see that people of color are often on the front lines when it comes to essential workers working in not only the healthcare, and they might only be the medical assistants or the nursing assistants, but also when you look at who works at the grocery stores and other places where they're first line. And so this impact has affected them from, one, the morbidity and mortality that is associated because of the inability, because of various health issues that people of color tend to have to experience, such as diabetes, hypertension, the heart disease, increased obesity because of the types of foods that they have or the types of exposure by living in a food desert. Also, you see the same effect from not only testing, where some of the testing facilities were located initially made it really difficult to get that, as well as the mistrust of people fearing, what were you going to do with my test results? Then we had to face the next issue was the hurdle of healthcare, because people did not experience the same level of healthcare, where people recently, we had a graduate student who went to the hospital and they told her that, can you read? She's working her PhD. And so this is just the stereotyping that people have and the implicit bias that you experience. And then the next phase was the vaccine distribution, where we've seen a continued level of disparity of people having the ability to get the vaccine, where nationally you see that people of color, if you look at African Americans, are only right now at 6% nationally receiving the vaccine. And the Latinx population and the American Indians are even lower than that. So you see this very large disproportionate with the abilities to even get, plus the abilities of people not having transportation, not having internet access, not having all of the things that is necessary to either go to the hospital, get tested, and all the others. So yes, this has just made a situation that was already bad worse.
Dr. Erickson, can you point to ways in which underlying inequities and disparities have led to differing risks and impacts of the pandemic for the people that you serve?
Sure, I think I see a lot of the same things that, my co-hosts on this have seen. I work at an LGBTQ youth agency in New York City called Hedrick Martin Institute, and a large number of our youth are youth of color, and many are homeless or marginally housed. They often live in unsupportive houses or in youth shelters where they get moved around frequently, and they don't have the stability that they need to grow into themselves. Even before the pandemic, the youth we serve were struggling to get their basic needs met, but at least they had places like HMI where they could come if their families were being homophobic or transphobic, where they could spend time with supportive peers, adult role models, people who saw them for who they were, where they could have a meal, do laundry, pick up donated clothes, pick up snacks, charge their phones. We even had paid internships. For many of them, it was their only source of income. And this all in an environment where they were surrounded by people who cared about them. But when the pandemic began, many of our youth ended back up in homes they didn't want to be in. Many were looking forward to graduating from high school, getting jobs, trying to get apartments with friends, or maybe they were already in college and they were forced to adjust to new lives or to move back home. HMI is open normally 6 days a week, and we've gone down to 1 day a week. And that 1 day is primarily now for filling basic needs and picking up supplies. We've shifted a substantial amount of work online, and so have all the other agencies like ours. And our youth used to rely on coming to see us, going to places like libraries, Starbucks, the LGBTQ center, places where they could be inside in public spaces, where they had access to water, bathrooms, Wi-Fi, and all of these kinds of spaces are closed. So instead, because it's cold, they're spending most of their time indoors, often in one room in a shelter or in a family apartment. This may not be a room that they have themselves. They may share it with roommates or siblings. They may have relatives around who are constantly reminding them about their queer identities not being wanted. So this is a point in their lives where they're trying to figure themselves out, to try on new identities. They don't have the literal space to do that. And sometimes they don't even have the figurative space. They don't have the privacy that they need to join virtual programs. They often can't find space in their homes or in their shelters. And the Wi-Fi isn't reliable often in their family homes or in their shelters. So yeah, to sum things up, the LGBTQ youth I see are pretty desperate to participate in their own growth, and they're at an age where they need to do that, and they were just barely making it through before the pandemic began.
Thanks so much, everyone, for sharing those perspectives on these really tough issues. I think there has been really broad coverage of the fact that people of color have experienced higher rates of illness and death as a result of COVID-19. We also know that people of color and underserved communities have really taken a harder hit financially as a result of the pandemic, with higher rates of food insecurity and housing instability. I'm curious, beyond these health and financial impacts, what are some of the other ways the pandemic is affecting people you serve that we may have been hearing less about? And what are the implications for health equity of these impacts going forward? I'm also curious if there are ways in which you think women and LGBTQ people have been particularly affected. And I'll start off with Dr. Nichols.
So thank you. You've seen that this has been affected for women in particular, because what you're seeing is often they are head of households. You're coming from a single parent household in many of the of our communities for people of color. You're coming from multi-generational households where the grandmother might be the person who is supporting her child plus her adult child, plus her grandchildren and great-grandchildren and that type of thing. And so the impact that we have seen is that if with the school systems particularly, if they don't have adequate internet service, if they don't have adequate, most of them, many don't have computers either. So therefore, you're already now in a multi-generational home where the person cannot adequately assist their children or their grandkids or great-grandkids with education. Also, the pandemic hit them because they're often frontline employees. And so when that occurred, one of the things that we saw is that if they managed to get COVID because they were multi-generation, has already been alluded to, that meant that they can't work. And so therefore they did not have the access that you typically see because now they can't work. And so they were the sole source of income. So you saw that. And also you have the whole stereotyping and implicit bias that you tend to see, because regardless of what level of education, there's the impression that you might be a very well-educated person, such as what we saw with the physician who could not get care earlier and that died, unfortunately, because they did not, she was trying to tell them that she was having pain and symptoms related to COVID. So often you see that because of that stereotyping of people of color, that you don't get the adequate care you need. Plus there's already the issues, like I said, of many of the disparities that were already present pre-pandemic.
Thanks so much. Dr. Erickson, what kind of impacts are you seeing that maybe have not been as well understood? Have there been any unexpected impacts that you've seen among the people that you serve?
Yeah, so in my role at HMI, I'm part of the counseling department. So most of my coworkers are therapists and I'm a psychiatrist. I prescribe medications and conduct evaluations for housing and other needs. And there are a lot of indicators that when the pandemic hit, our youth members were impacted really significantly in terms of mental health. So we looked at our data for a portion of 2020 during the pandemic and compared it to the year before, 2019, before the pandemic. And we found that clients were asking for much more frequent counseling visits and that I had a third more initial psychiatric evaluation requests. And I'm no longer physically in the office, but I'm busier than I've ever been. My appointments are booked back to back every week, and I'm meeting with youth who are having all sorts of pandemic related issues. The most common ones are ones that I've named already, like having to spend most of their time in one room at a shelter or a family house and not having privacy. When I meet with youth, they're sometimes in stairwells or closets or outside freezing, you know, when weather permits, whispering or having to get off of calls early. Their Wi-Fi may go in and out during sessions. It's hard to have fluid conversations and really understand what's going on with them. And they talk about feelings that they're really not moving forward in life. You know, this is the time when they should be meeting new people, getting their first job, going to school, and there aren't jobs available. And a number of my clients have actually had to quit school because their Wi-Fi hasn't been reliable enough to participate. And this is even in, you know, city-funded shelter systems where the Wi-Fi should be expected to work well enough to participate in school. My trans clients in particular have run into a lot of health systems issues. So health clinics are overwhelmed, trying to shift to a virtual model. And many of my clients have been having trouble getting in touch with their clinics for refills of their hormones and other medications. And it's even harder for others who haven't started those medications because finding a new provider during this time is really difficult. A number of my clients had surgeries scheduled, and then the pandemic hit and the surgeries got pushed off as hospitals rushed to set up COVID units. Thankfully now some of that is coming back online. In terms of positive changes, there's one area where the pandemic really has helped my work, and that's that there have been these massive changes in regulations around virtual appointments, which weren't really allowed prior to the pandemic. So prior to COVID, many of my youth clients made appointments and then missed them. So I had a lot of no-shows. This was for various reasons. Some of them just forgot about them completely. Some of them forgot until the day of, and then they lived in a far out borough and didn't have time to get in or didn't have the money to get in. A Metro card costs $275. So that's $550 back and forth. Or they needed to prioritize other things like making sure they got a filling meal that day or that they made money somehow. So now I have virtually no missed appointments. All my clients are scheduled for video calls. And if they don't show up, I give them a call on the telephone and they pick up. The other positive that I've noticed is that for trans youth who feared transitioning because of the period of time they would need to spend sort of essentially going through puberty in front of the world, they worried they would feel awkward or people might judge them. The pandemic has allowed them to transition out of the public eye in a little more personal space and to have a little more time to witness the changes to their bodies and adjust before the whole rest of the world gets to see them.
Thanks so much for really highlighting, I think, a range of different ways that people have been affected by the pandemic that we maybe have not been talking about so much. And really any place where we can find a positive during these days, I think is always helpful. Ms. Echo Hawk, what are some of the things you're seeing that you think maybe have not gotten a lot of attention in terms of how your community has been affected by the pandemic?
Yeah, this country has a crisis of missing and murdered Indigenous women and girls and violence against them identifying LGBTQ plus two-spirited community members. And we have actually seen that amplified in this time of COVID-19, in particular reports of individuals who then became quarantined with their abusers. And so, or their abusers weren't leaving home for the 8 hours or whatever hours they used to go to work. We're seeing this impact their children, again, because they are quarantined with abusers. Or there is less interaction and less response from law enforcement when law enforcement is called to domestic violence incidences, and in particular in our reservations and villages where they simply don't come at all. And as a result of that, we're actually seeing more increases in violence against them identifying people within our communities. We've seen an increase of murders. Nationally, prior to COVID-19, murder was the third leading cause of death for our young women. And this has been amplified by the COVID-19 crisis. My organization recently had the opportunity to speak to survivors of sexual violence in 26 cities across the United States who were urban Indian peoples. And what we found is 20% of them, their biggest concern was the increase of the lack of physical safety for them. And these were already survivors of sexual assault and domestic violence. So this has been a deep increase, and we have seen our community respond and doing all of the services we possibly can. But again, there's chronic underfunding of ensuring the safety of Indigenous femme people across this United States. And we are doing the best we can with the little that we have, but people are more afraid of letting somebody come into their home that may be fleeing an abuser because of COVID-19 and not wanting to expose their families to these possibilities. In addition to that, we are seeing the loss of our elders, those elders who hold our culture and our tradition because of the constant and ongoing colonialism that is looking to eliminate Native people in this United States. We have in some tribes, for example, where there's only 10, 15 fluent language speakers left. And our language is an essential part of who we are in both our spiritual, cultural, and language practices. And when we lose one person, we lose an entire library of knowledge, and those losses have been deeply impacting in our community. I have to echo the positive change in regards to having the ability to provide telehealth services, including to those relatives who are experiencing this lack of safety, are looking to spend time with counselors for domestic violence, sexual assault, also with physicians to talk about the damages to their bodies as a result of these assaults. And with the expansion of telehealth and the changes in the federal regulations, we have been able to provide more services at the Urban Indian Community Health Center that I work at. However, we need to ensure that these are continuous after the pandemic. We didn't just need them in COVID-19, we needed this ability prior. And so we need to make sure any positive changes, such as the expansion of telehealth and the ability for community health centers and others to provide these services, is maintained even after COVID-19.
Thanks so much for sharing those thoughts. And I think I have heard that some tribes have been, in fact, prioritizing elders who speak the native language for vaccinations, very much for protecting the languages and traditions that are at risk, as you mentioned. Dr. Galvez, your thoughts on this?
Absolutely, thank you. And I also want to highlight the psychological impact that this pandemic has had on my community, the Latino community. And I would like to just briefly share with you a story of a patient of mine who I will call B. She is a single 45-year-old female mother of 2 children, and she caught COVID in December working at a meatpacking plant. And even though she was not hospitalized with COVID, she was quite ill at home, and she was in bed for an entire month, sick, short of breath, tired. And during this time, her 2 children had to essentially fend for themselves. She talks about being in a separate room and not wanting to be near them because she was living in sheer terror that she would infect her children. Her 13-year-old had to step up and take care of her 8-year-old brother and mom. They have no family in the area. A friend would drop off food twice a day. And B is now 2 months out from this infection, and she has had to return to work because she didn't have a choice. She lost her job. She is now working at a fruit packing plant, and she still has no benefits. She has not been able to get vaccinated, and she's had to work because she doesn't have sick leave or unemployment. But what I want to highlight here is that despite her physical health not being well, what she worries about the most and what has really hindered her full recovery is this deep guilt that she has. It's a trauma that she has not been able to care for her family the way she feels that she should. She hasn't been able to care for them financially, and she has not been able to provide for them as a mother should, is what she tells me. And she tells me of a story that her son was so desperate to just be held by his mom during Christmas because they had to be separated during Christmas in separate rooms. He put himself in a blanket and just came into the room and just kind of nuzzled against her and then left the room. And she tells me that she closes her eyes and this is what she sees. So absolutely, we have to pay attention to the psychological impact that this has had, and it's hindering people's full recovery. And we need to ensure that people have access to healthcare and mental health services, but this is not happening, even though we have essential workers. And I want to echo what people have said is there have been some silver linings. One of them is that we have seen partnerships grow in our community so that we can bring some services to our patients. We are also Migrant Clinician Network, which is the organization that I represent, is providing a mental health training outreach to community health workers to bring education about mental health to the community. But it's not enough. And as Ms. Echo Hawk said, we're worried about this now, but as people start to recover, my fear is that we're going to forget these people that have been suffering. And we cannot forget this. This is our time. And it's not just about talk. We have to translate this into action and bring policies that actually protect families.
Thanks. And that transitions perfectly into the next thing I'd like to discuss, which is really where do we go from here? So it's clear the pandemic has shown such a bright light on the really stark health inequities that were in place long before the pandemic. And there's now a heightened awareness and focus on them. We're hearing the many ways in which disparities may be widening both today and potentially in the future. But do you see this heightened attention and focus as providing a moment of opportunity for any real progress here? And if so, what are really the most important steps that need to be taken to help close the gaps, not only related to the pandemic, but also to those broader inequities that were in place before it? And I'll go back again to start with you, Dr. Galvez, on this.
Thank you so much. Yes, absolutely. This is an opportunity for all of us, especially advocates of all communities of color, to really stand up and demand. I think one of the things that we need to emphasize is that we really have brought these inequities to light. We've helped the community understand these, but understanding does not necessarily mean good policy. And so we need to start to demand policy. And for the community that I represent, this means healthcare for all, especially essential workers who are on the front lines, making sure that we have food to eat. But we also need to make sure that people who are going to work have safe working conditions. The working conditions in this country are very lax and often not enforced. And right now it's up to the employer to enforce. We need to have sound policy so that worker protections are enforced and people who do make a complaint aren't retaliated against. We also need to make sure that they have sick leave, hazard pay, access to stimulus money, childcare for people that are leaving their home. So I think there is several policies that we can certainly begin to demand. And I think they need to happen now because we know that another pandemic or another health crisis may hit. And if we don't work on these conditions now, we're going to see the same disparities in the future. It's not only about taking care of the people that we have now, but it's really taking care of our future generations. We know that our future generations, their communities, many of them are coming from communities of color. And all of these psychological and health problems trickle down to the community. So it's an investment in our future.
Great, thanks so much, Ms. Egohawk.
Yeah, absolutely. There are so many opportunities right now, but we have to really think about where and how did these health disparities develop? And we can't have this conversation without talking about the fact that this is from ongoing structural racism embedded in our systems of policy, of resources, of procedures, and everything from policing to the way that healthcare is provided that is directly impacting the health and well-being of our community. And this racism is so deeply embedded that when challenged, folks feel uncomfortable and say, well, it wasn't me. And in fact, as recent as less than a week ago, the Journal of the American Medical Association recently drew a lot of outrage by tweeting, "No physician is racist. So how can there be structural racism in healthcare?" This is one of the leading organizations for medical professionals like myself and scientists. And this is what they're saying about structural racism when we are watching our community, like was mentioned before, a Black physician die as she talked about the healthcare she was receiving that wouldn't listen to her as a Black woman. And I am seeing my community experience that right now. And so even though we are talking about the inequities, we're talking about health equity, because of this structural racism, which was exhibited by the Journal of the American Medical Association in the way that they talked about structural racism, we as people of color in this field are working and have been yelling and screaming about this for decades. We need the allies, the people who like to say equity, but aren't actually implementing it, to step up and challenge with us. It is not just our responsibility to end this structural racism. That is our opportunity right now. And the awareness in the country has been raised, but we have to move beyond rhetoric and we have to take that into action. And if I look at my community, the American Indian Alaska Native community, they should be coming to us right now on COVID vaccine, the entire country, not because they think we have all the problems, but because we have the answers. We have communities that are 70 and 80% vaccinated right now. One of the tribes in Washington is vaccinating all of the teachers in their county. Anybody who is a teacher, because the county is not doing that for their teachers that they are demanding go back into the schools. So the tribes are doing it for them. And we are seeing that across the country. Again, we are leading in vaccinations because we have held onto our cultural value systems of caring for each other for the next generations, because it is our responsibility to be a good ancestor to all people, not just American Indians and Alaska Natives. And we are seeing that evidence now. We need folks to come to us because we have the answers, not because we have the problems, and stop saying equity, put it into action.
Thank you so much. And I think this point about learning from and allowing community to lead is so important. So thank you for those comments. Dr. Erickson?
Sure. I swear I'm an optimist, but I'm also a realist. And I really think that it takes people recognizing the underlying structural inequalities that are there before anything's going to change. And I'm afraid we're not going to learn the lessons we need to learn, and we're going to return to the same or even a worse place than we were before. Because in times of scarcity, the wealthy and the connected kind of always seem to be able to hold on to what they have. And then sometimes I start to think that when the inequality becomes so great that you can't not look at it and it stares you in the face, then we're going to have to act. So I've been riding the subway back and forth to work, and it's a different landscape than it was before COVID. Many of the middle and the upper class people who took the subway during normal times have bought cars, they've bought homes in the suburbs, or they're just staying home in their neighborhoods and going to work on Zoom. They don't have to physically go to work like the majority of lower middle class and poor people who live in the city. So these days, the subways are all essential workers, home health aides, grocery store workers, construction workers, and also homeless people who often have substance abuse issues or major mental illness. And the subway is really rough right now. But the thing is, those people were always there. We were just not seeing them. Maybe because there were so many other people, but now everything is in full view. And I guess I ask myself, in whose full view? My fear is that the people who have the power to change things are not the people who are getting on the subway, and they're not the people who are going to see what's happening. I do see some positive changes. There are signs that New York is trying hard to target vaccines to groups that need them the most. For example, where I work up at Columbia, there's a large armory in Washington Heights that provides vaccines. And when the city noticed that a large percentage of the people receiving vaccines were coming from wealthy Manhattan neighborhoods or from the New York City suburbs, they actually implemented changes so that now a large percentage of vaccines are required to go to New York City residents from surrounding neighborhoods like Inwood, Washington Heights, Harlem, and they actually have numbers for this. I was also in a deli the other day. A vaccination outreach worker was going out on foot, scheduling appointments on the spot for people who are working in small businesses. The city's also prioritized those who work in public service jobs. So the staff members at Hetrick Martin, where I work, have all now been offered vaccines so that we can start working with youth when we can start up again. And as I said earlier, in terms of LGBTQ youth, the opening up of virtual spaces has significantly expanded online support. And I think actually this is going to be especially important for rural youth. I work in one of the, the biggest city in the United States, but an LGBTQ center in New York City or another large city typically has groups in person. Now everything is virtual, so a youth living in a small town or rural area wouldn't have access before, but now actually can attend these groups with youth from all over the country. And it's all run by an LGBTQ center thousands of miles away from where they live.
Thanks so much. And Dr. Nichols, if you can help us close out with some thoughts on the steps we need to make progress going forward.
So just like my colleagues have said, I have been very happy about many of the progress that we've seen, particularly the attention on telehealth, mental health. Those are things that we're focusing on, that various organizations are showing us, are making statements about what they perceive as systemic racism, and that we need to put an end to these things. But I think the important thing is what my colleagues have said, is that we don't want this to be something that's in the moment, that right now this is the right thing to do because we are seeing the disparities. I want the policies to continue. I want them to put a focus on all populations, for those that are brown and Black people, people of color, for the LGBTQ population, for our American Indians and our Alaskan and our Hawaiian, Native Hawaiians, and every organization, our agents, just not for one population. I want them to look at that we are a country that is a very diverse country, and that we have many disparities with social, economic, and that the focus that we're putting on, that is being highlighted, that we need to get our government officials to look at supporting us and continuing this progress that we have made. And that for the different philanthropic organizations who have been supporting us, and I'm very appreciative of that they also continue this support. And that the various companies who are now offering additional safety, like on the subway systems and in the airports and how they're cleaning, that doesn't just end, but it continues. So I want the progress that we have seen to continue, and for us to try to make sure that it is health equity for all, and that we give people what they need in the amount they need in order to ensure that we all have equal access to healthcare, equal access to different types of benefits, and that we are not just a in the moment time, that this is an always time. And that when also, my final thought is that for vaccinations, that when people's opportunity to get vaccinated comes up, that they take advantage of that, and that we do what we can to protect ourselves and also our loved ones.
Well, I think that's a great place for us to end our discussion today. I wish that we were not out of time, because I feel like we have just begun to scratch the surface of these issues. I really enjoyed having the opportunity to have this conversation and hear all these diverse perspectives on these issues. I think for me, it really hits home that as we hopefully move closer to a recovery from this pandemic, that we must really continue to prioritize and center health equity as part of those efforts. And that is going to be important not only for responding to and continuing to recover from the pandemic, but also for advancing health equity more broadly. So thank you so much for your time and for sharing these really important thoughts today.
Thank you for inviting us.
Thank you.
Thank you, Samantha.
What an incredible day, and what important conversations. Thank you so much to everyone who joined us for the 19th Represents Resilience and Recovery, especially those of you tuning in from home. If you liked what you saw today, we'd love it if you'd join us as a member of the 19th. As a nonprofit newsroom, members help ensure that our journalism remains free for all to read, and that our events remain free to attend. Even $19 helps. You can make a gift at 19thnews.org. If you missed any part of today's program or just want to rewatch, visit 19thnews.org/events. A special thanks again to our generous sponsors, 3M, AmerisourceBergen, Pfizer, and the Healthcare Distribution Alliance. We hope to see you in April for our next event on gender and climate. And just a reminder that you can get notified about all of our future events by signing up at 19thnews.org/subscribe. Thanks again. We will see you next time.